She's middle-aged girl. She has been here because she needs to discuss something. Yeah, you don't have, this is a problem. This is a problem and it keeps going in the past few weeks, by the way, Dr. Elvira. So just pick up the relevant data from here. The relevant data from here. Just pick it up from here because this script is lacking in aspirations. Okay, so for the fibroadenoma, guys, this is quite simple. Quite simple station, but just if you do not know it prior to the exam, this is a problem. Why? Because you'll be confused. Hello everyone, hello Dr. Yasmin. Can you hear me? Okay, so here simply the girl is panicked and she booked an urgent appointment to discuss her problem with you. She found a lump in the breast. Okay, talk to the patient and do relevant examination. The task here says do relevant examination. Okay, do relevant examination, it means that you should prepare yourself to do examination. Okay. Okay, so can anyone tell me how to elaborate the breast lump? Because this is the core of the station. I need someone, Dr. Elvira, join me in this. Join me in this, and I will help you. Elvira? Okay, can anyone join? Dr. Zaid, join me.
Hello, yes.
Hello, Dr. Zaid. How to elaborate a breast lump?
So, hello, my name is Dr. Hamad Ali, I'm a junior doctor here. So, tell me what brought you here to the clinic?
No, I just need how to elaborate the lump.
Oh.
Okay, doctor,
okay.
I noticed some lump in my breast.
Okay, tell me where since when you have the problem?
Doctor, it has started maybe like you can say. Wait, let me check. Actually, I think it started like maybe 4 or 5 weeks ago.
Okay, does it does it change in the size?
No, it's just small size, doctor.
What about any? Okay, is it in one breast or two breasts? Or sorry, in one side or two side?
No, it's one side only, like the right side.
Okay, and anything else?
Dr. Zaid, is this your own elaboration?
Okay. Okay. No.
Dr. Elvira. Yeah. Okay, no problem. Just because Dr. Elvira just said something. Okay, no problem. I'm not laughing. I'm sorry to interrupt you, Dr. Zaid. I'm sorry. It's just about Dr. Elvira comment.
Okay. What about the? Could tell me how about the size of it?
It's a small in size, Doctor, like a coin. Very small.
Okay, and have you noticed any lumps in other part of the body?
No, doctor. This is your only elaboration, Dr. Zaid?
No, I should ask about the size, and
exactly. So you know everything. Why don't you ask? Ask me.
Because it's difficult. How do you describe for me this the size? How big is this one?
Okay, Dr. Zaid. Okay, watch me. Okay, no problem.
Yeah.
Let me ask. So, where is? Can you tell me which breast exactly? I mean, of course, after asking, can you tell me more? She would tell you what you want to know, doctor. Which side? If she would tell you, for example, right side. What about the size? She will point you like a coin or even smaller than a coin. Do you have any pain? No, so it's not painful. Okay. So what about the site? She will point you maybe she will point at the right upper quadrant or whatever. Okay. So site. What about the shape of the lump? She will tell you, doctor, it's just rounded. So now I elaborated the side shape and the pain, if it's painful or not. Okay. Now I need to ask about the breast itself. Have you noticed any change in the breast in terms of size or shape? No. What about the nipple? Any bleeding? Any discharge? Remember, guys, we elaborated this in the intro session. So I asked about the lump itself in terms of size, pain, and the change. I also ask about the breast itself in terms of any change in the breast, in the size or shape. I ask about the nipples themselves in terms of any bleeding or discharge or nipple retraction. Here, you will find that the mass is small, rounded small mass in one side of the breast, and it's even freely mobile on the examination. So, do not forget to ask also about the armpits. Any change in the armpits, like any lumps or bumps in armpits? No. So this is the elaboration of the breast. Simply. Again, for anyone who missed that, number one, I will ask about the lump itself, about the site of the lump, the size of the lump, and I will ask about the shape of the lump as well. Is it painful or not? And have you noticed any change in it or not? Then I ask about the breast itself, any change in the breast in terms of size, any change in the breast in terms, for example, of shape. What about you can also add about the nipple. Have you noticed any bleeding or discharge from the nipple? Any retraction from the nipple? One more question also you can add to the breast is that any thickened or dimpling skin of the breast. Okay, so here simply I told you that the lump is not conclusive for anything. It's just small lump, small rounded lump, which is like started like few. Yes, you can add. I told you about thickened or dimpling in the skin. You mean attachment to the overlying skin, Dr. Safa? Dr. Safa, you can't ask this to the patient. I mean, how can she know if it's attached to the overlying skin or not? You will examine it and you find it by yourself. Okay. We keep asking still many questions to ask. So I elaborated the lump, dimpling simply. Any change in the overlying skin at all, any thickened or dimpling skin, we asked about this. So now let's move to the DDs. What are your DDs, Dr. Safa, here? Dr. Safa?
Just a second. Hello?
Yeah.
Okay, yeah. DD's breast cancer, the most dangerous one, first of all.
Okay.
And fibroadenoma.
Okay. How to ask about the breast cancer?
We'll ask about weight loss and loss of appetite, tiredness, that kind of
Yeah,
thing.
exactly. Symptoms of cancer, you mean, right?
Yeah.
We can also ask about trauma,
Yeah, trauma.
right? If there's any trauma. Okay. So these are your two DDs here in this station. So for any breast lump, I need to ask about cancer and trauma. Very simple. Okay? Okay. So here there are some sets of questions not to miss in this station. After elaborating the past medical history, which is very important to ask about the family history. Family history is very important because family history is highly suggestive of breast cancer. So what are the set of questions that I must ask after the PMH or the past medical history, Dr. Safa?
Hello?
Yeah,
Sorry?
Dr. Safa. What
What's
are
the question?
the most important questions to ask after the past medical history here?
The lifestyle questions, but I
You
can't
can
really
ask
tell what
about
bearing they would have.
smoking.
In a woman, it would be the 4 Ps. Have
Yes,
we done that?
perfect, perfect. So after
Yeah.
the past medical history, I told you before many times, guys, after the past medical history, you must ask about the 4 Ps if there is any female. If you find any long hair in the cubicle, ask about the 4 Ps. You know, if he is a male with long hair, ask about 4 Ps. Do not forget to ask about the 4 Ps, guys, please. Why? Why? Because the people who do not ask about the 4 Ps in this station, they will not pass it. This is the crucial and the important. three important things in the history of the breast. Number 1, family history. Number 2, rule out malignancy or cancer. Number 3, the 4 P's. Why? Because early menarche and late menopause are precipitating or risk factors for breast cancer. So you must ask about when was your last menstrual period and when was your first menstrual period. First menstrual period is for the puberty or menarche. Okay, so is it regular or not? Have you ever been pregnant before? Because no pregnancy as well is risk factor for breast cancer. So early menarche and late menopause. I must ask about the 4 P's here, very important to ask. Okay, now move to the examination. But Dr. Safa, you are still on the stage. Tell me.
Yes, sorry. I meant that we'd also ask whether she breastfed her kids or not, because
Excuse
that's
me?
also a risk factor. We would also ask her if she breastfed her kids or not.
Okay, ask about that. But what if she tells you I was not pregnant before?
Yes, well, of course, after we ask about the pregnancy,
Yeah,
previous pregnancy.
exactly. So
Yeah.
don't you want also to ask about the OCPs?
Oh, yes, about the OCPs as well. Pills.
Yeah. So the 4 P's are very important, very important in such situation. Please do not forget to ask about them, guys. The 4 P's are very important. Ask about them in details. Such stations are very important. I mean, they are very short. The breast station is like a gift to you. Why? Because they are short already. So do not waste your time or do not panic and do not cut your history short. You have to be very concise in the 4 P's here. Which examinations are you going to do, Dr. Safa?
We'll verbalize all the examinations, the general physical examination, and then specifically the chest examination, the breast examination.
Okay.
I think that's it.
You mean the breast, not chest, okay?
Yeah.
Don't say chest. Okay, so it's fine if you mention even chest, it's fine. But I want to tell you that you have to be specific. Why? Because in the breast examination, you have to say, I'm going to examine the breast. The breast examination includes the axillary examination as well, Dr. Yasmin. Full breast examination includes the axillary lymph nodes. So here, in this case, you are going to examine the breast. Okay, you know the examiner will give you a paper full of many findings. You know what are the important things in the finding? That number 1, the lump is in the upper outer quadrant of the right breast. Number 2, size is small. Dr. Safa, are you with me?
Yes, I'm following you.
Okay. No change in the skin at all. The shape round in shape and the consistency is firm. So round shape, firm consistency, smooth surface, not tender, not attached to the overlying skin, not adherent to the underlying tissue. You know what does this mean? And as well, mobile as well, freely mobile. So this is simple mass, freely mobile mass which is not attached to overlying or underlying structures and is smooth and firm, and this is benign structure probably, Dr. Safa, right?
Yes.
Very benign, something very mobile and smooth. So what is the most benign problem, or what is the most benign growth in the breast?
Fibroadenoma.
It's the most common. 75%. 75% of the breast growths are fibroadenoma.
Yep.
Okay. So, doctor, what's going on?
Well, I'd like to tell you that you have from what I've seen and what I've assessed and examined your breast, I found that you have a condition that we call fibroadenoma.
Okay. Doctor, what is this?
It's a completely benign condition. It's a harmless condition in which there's a mass or a lump in the breast.
Doctor, is it cancer?
So far from my examination, I'm pretty sure it's not cancer.
I will kill you.
Okay. Why do you think, is there any particular concern you have in mind?
You're sleeping when you are answering.
Sorry, I forgot.
You didn't forget, you're sleeping.
Probably.
Yes, okay. So, doctor, I'm really worried because my aunt has had breast cancer and I'm really worried about her. I'm worried about me.
I'm sorry to hear about your aunt. From my examination and my assessment so far, I suspect that it isn't cancer and it isn't anything harmful or malignant. However, we'll be doing further investigations just to make sure.
Okay. So here, Dr. Safa, I just need to add one thing. Here in this case,
Yeah.
from my examination, it's unlikely, or it's less likely to be cancer. Okay. However, in order to be sure, still, in any breast growth, Dr. Safa, you need to
Yeah.
refer her to be seen by specialists. Any breast growth in
Okay.
the body. Why? Because the woman who develop breast growth sometimes can be at high risk, especially if there is a high family risk of cancer. They can be at risk of developing cancer after a while. Not because of this growth, but I mean generally. So what you can do is that you send her to be seen by specialists. Okay, so in
I
order
have
to,
a question.
yeah,
Even the cyclical mastalgia case, we don't refer that, do we?
we will talk about this in a while.
Okay.
Why are you talking about cyclical nostalgia right now?
I just remembered. Sorry.
Cyclical nostalgia is a combined station. We'll discuss it in the
Okay.
combined station. No worries about that. So, Dr. Safa, you are going to tell the patient, however, to be sure or to reach the best possible diagnosis or the exact diagnosis or the exact cause, we need to we need to do some tests for which we are going to refer you to be seen by specialists.
Okay.
Okay. So now what next?
I'm sorry.
What's next? I mean, you are going to refer her to specialists.
Yes.
What next?
And
What will the
then
specialist do?
we'll do the tests, the ultrasound, the mammogram, maybe an FNAC.
You know what? She's 27 years old. Ring any bells?
Sorry?
She's
Didn't
27
catch the
years.
last bit.
Huh?
What are you saying after 27 years old?
She is 27 years old.
Um,
Ultrasound, not mammogram.
Ultrasound. Okay.
Okay? So mind that,
Okay.
please. Okay. So you're going to refer her to specialist. What will the specialist do? When anyone asks you any question in PLAB 2, what will the specialist do to me? Say what all the specialist is going to do. The specialist is going to do 1. Detailed history. 2. Physical
Okay.
examination and breast examination. 3. Ultrasound. After the ultrasound, they may consider taking a sample, which is fine needle
Okay.
aspiration. So history, examination, and investigation. Okay, now I should ask
Okay.
you one awkward question. How quick or how long it will take me to take an appointment? You know what happens usually in these cases? You refer her to the hospital. The hospital will contact her for a while. I will the hospital, for example, now you will refer her like you will do electronic transfer to her, like online transfer or on system transfer. The hospital will contact her after a while, like after a few minutes. So the hospital will contact her and they will give her an appointment within 2 weeks. For any lump in the body, either breast or anywhere else, you will give an appointment within 2 weeks. Okay, because you are in GP, so you need to refer to a hospital. What will the hospital do? They will contact her and give her an appointment within 2 weeks. Okay, sometimes she will ask you how will the test be run. You will now explain the ultrasound. What is the ultrasound? High frequency wave applied on the breast to show the structure of the breast. Very simple. High frequency wave to produce detailed image about the structure of the breast. Okay, if she asks you about the sample or the biopsy, it is usually ultrasound guided biopsy. Okay, so the ultrasound will guide the doctor or will guide the needle to the exact site of the growth. And when it is in its place, the sample will be sucked out of its place. I mean, like it will be ultrasound guided. Doctor, when will I get the results of the test? I told her that she will be seen within 2 weeks, right?
Yes.
Okay, so the results depend on the type. For example, there are some breasts like one-stop clinic. There is something called one-stop clinic. I mean, if the hospital give her an appointment within 2 weeks to be seen in the one-stop clinic, this one-stop clinic will do the test and they will give her the result within the same day.
Okay.
But in some other clinics, the results may be available like maybe later, like maybe 1 week. So it depends on the type of the clinic. Some clinics you can do the test and get the result on the same day. On some other clinics, it needs to be you need to wait for a while to get the result. Sometimes also she may ask you this question, Doctor, why do you think it's not cancer? So tell me, Doctor Safa, what's your opinion?
I will explain all our findings from our examination and the history that point to it being benign.
What?
For example, from the history, we can tell that she doesn't have any of the signs of cancer. For example, any weight loss or any dramatic weight loss or any change in her appetite or any weakness or anything like that. And from the examination, we found that it's a small, firm, round mass. It's smooth. It isn't attached to the overlying skin.
Perfect. So from the history and from the examination, from the history, no symptoms suggestive of cancer. From the examination, it's pretty mobile and it is not painful and it's small inside, which are not usually the signs of the malignancy.
Okay.
Doctor, she will ask you, Doctor, I mean, before telling her that we need to do further investigation, she may ask you, Doctor, I do not want to be ignored. I want it to be investigated. Please, I want an urgent appointment. This is how you are going to tell her we are going to refer you immediately to the hospital and they will give you an appointment within 2 weeks.
Okay.
By the way, the hospital will give her appointment within 2 weeks. You know, they will give her an appointment in the surgery section. In the surgery section, there is something called breast clinic. There is something called breast specialist. So she will be seen in a breast clinic in the hospital under the supervision of breast specialists. Very simple. Anyone needs any question here?
Dr. Ahmad, on my day, the last question that girl asked that, okay, so today you are not doing anything for me?
Simply, you cannot do further things. You are going to refer her to the hospital right now. This is what you can do. Because actually you cannot do ultrasound, you cannot do mammography, you cannot take biopsy definitely. But just one thing, you're just going to give her some warning signs. If you notice in the future any change in your armpits or any change in your breast, please feel free to come back to us.
Yeah.
Because you can never do anything. It was not painful, it was not showing any signs.
So I can say that I'm going to refer you, I'm making the referral just now and I'm sending you to the breast clinic, right?
Yeah.
Today. So what you are doing?
No, wait. You are sending her to the hospital. The hospital will contact her or will receive her and they will give her an appointment within 2 weeks because you are in GP. Okay, so in GP you have to send her to the hospital because the hospital will be containing the specialist. Okay, so the hospital will contact her and they will see her and they will give her an appointment within 2 weeks.
Okay, they will make a referral to breast clinic. Okay.
Yeah.
Got it.
So anyone has any questions so far? Okay. This is the fibroadenoma station, a very simple station, but I told you guys it's not present in some notes. So please mind it. And it comes too frequently. You know, I think it comes just because you know that some people are lacking. You know, when they know that some stations are lacking, they focus on it. Okay, next station is one of the challenging stations, ductal carcinoma in situ. Here the test tells you frankly that she is a lady or she is a woman, 53 years old woman. She has been in the breast screening program a few weeks ago. She has undergone mammography or mammogram, and the mammogram showed some changes for which she has undergone fine needle aspiration cytology. The needle aspiration cytology has been received by the nurse colleague, and she told the patient that the cause of doing this test is to detect an early stage of breast cancer, and she may have breast cancer. So a nurse colleague told her that this is one of the reasons. One of the reasons is to detect early stage of breast cancer, which is the case, which can be the case with her. Okay. Actually, here the test will see that the fine needle aspiration cytology has been done, and the results show that the possible diagnosis is low-grade ductal carcinoma in situ. So the result or the diagnosis here, she is diagnosed with low-grade ductal carcinoma in situ. She has a report and she wants to discuss the management plan. The consultant is busy at the moment, and you are going to talk to her. Special note, please do not examine the patient. So here you are not supposed to examine the patient. And the consultant will talk to the patient later about the treatment options. What you must do, talk to the patient, discuss the report, explain the initial plan of management, and address her concern. Why do they say initial plan of management? Why? Because simply this is not your job. This is not your job to explain the further plan of management here. What you're going to do right now, you're going, by the way, guys, don't you think, Dr. Benign, how are you today? Dr. Bina?
Hello. Yes,
Yeah?
hello. I'm good, thank you. How are you?
How are you, Dr. Bina? I'm fine. I just need to ask you one question. When someone is diagnosed with ductal carcinoma in situ, don't you think it could be something, I mean, like something sometimes disappointing or devastating or whatever?
The point in what? What did you say? Sorry.
I just wanted to say that if she is ductal carcinoma in situ, don't you
Yes.
think it will be good news to her?
No, it's bad news because oh, you mean that way. I think it doesn't spread that much. I think that's why, but obviously it's cancer.
Yeah. So don't you think it
But it
could be?
doesn't spread to the surrounding structures. Yeah, it could be. Yeah.
It could be what?
Good news in a way, but obviously it's cancer.
Yeah.
So
So why don't I break it bad?
yes, you can.
Right?
Yeah.
Okay. This is a good point. Actually, we need to break it bad here. This is something you have to look after here. So here you're going to take some history. Again, you will elaborate the breast lump. You can mute yourself, Dr. Bina, if you wish.
Okay.
You can mute yourself, but just the important thing is that when you are disclosing, you're going to tell the patient, for example, do you have any idea what's going on? She will tell you, no, doctor, tell me the result, please. So now you'll tell her you have been referred to take a sample, and we found something in your breast, for which we have done this sample for you. So you have been referred for mammography, and we have found this, some change in your breast, for which we have referred you to a sample. So, do you have any idea about the result? Would you like me to? Sorry. Actually, I don't have encouraging news, or I don't have very good news, or I don't have good news here. So it's just sort of breaking bad. I don't have good news actually. The sample shows that you have a condition we call early stage of ductal carcinoma in situ. Why, guys? I'm breaking it in a bad layer, or I'm breaking it in layers. You know, the word carcinoma itself is disappointing and scary. So even if it is good prognosis, or the cancer is having good prognosis, or even limited, or even borderline cancer, why don't I, mind the word carcinoma itself? So here, some people from some academies play it this way. Actually, I don't have good news, but as well there are some. Actually, I don't have good news, but there are also some other good news. So let me tell you what we found. We found this one, ductal carcinoma. You will explain to her the diagnosis. Oh my God, doctor, cancer? Well, actually, the good news is that it is limited cancer. You know what does this mean? Okay, let me explain to you. So now you broke it bad in layers. Just break it bad in any way, but I need you to be a little bit careful about it when you are telling her that she is having DCIS. You will tell her, let me tell you, or let me explain to you. It is an early form of breast cancer and accounts for like around 10% of the breast cancers. And it's basically located in the duct, the milk ducts in the breast. But the good news is that it remains within the duct. That's why we call it in situ, which means that it is limited in space. So the good news is that it is limited in the duct. So this means that it never goes beyond this place. So it doesn't have any spread. And that's why it is very good prognosis. So just simply, it is limited, that's why it's having good prognosis or good outlook. Say outlook, don't say prognosis, because prognosis is sort of medical jargon. Doctor, this is quite shocking to me. What the nurse in the hospital told me, doctor, you know, she told me I might have cancer, but doctor, I didn't have any abnormal thing in my breast. I do self-examination of the breast from time to time. I'm feeling guilty, doctor. Maybe I was doing the breast examination wrong all the time. So now she's underestimating what she's doing. Now you keep reassuring her and tell her that it is most probably, guys, when someone, you know, such lumps, by the way, any breast lump or any unhidden lump in the breast usually are picked up by the routine breast screening, right? So now you have to stress on the importance of the breast screening. So you will reassure her that don't worry, please, you are doing the right thing. That's why we advise all our patients to come for the UK routine breast screening program, because such lumps are often picked up only by the mammogram. And they are usually having no symptoms. That's why we will detect them by scans and doing some cytology or some sampling. So now you have to stress on the importance of the breast screening. Doctor, is it serious? Will I die? Now reassure her again that fortunately, first of all, it is like limited type of cancer, never spread. This is number one. Number two as well, that her condition is low grade. You know, the test tells you that it is early stage ductal carcinoma in situ or low grade ductal carcinoma in situ. So here it is first of all in situ, and number two, it is low grade. What are the treatment options? You will tell her that we're going to refer you, or you're going to have a talk with our consultant as mentioned in the task, and he can recommend you the treatment surgical options. What could be the options here? Simply wide local excision or mastectomy. Wide local excision, which means that area of the breast will be removed, or the whole breast will be removed. So now there are two treatment options, either wide local excision or mastectomy. Okay, now she will tell you, doctor, I don't want my breast to be removed. I don't want to go through this operation. Again, you will have a talk with my senior, definitely, and you will discuss the best treatment option which is more suitable for you. However, the chances of getting mastectomy is high under some conditions, like if the area, if the growth is large, or if you have a small breast. Small breast means that wide area of the breast will be affected by the DCIS. So if you make wide local excision, it will not be any different from the mastectomy. However, after that, we can arrange for you breast reconstruction. What about the lumpectomy, doctor? What about, she will ask you, doctor, what about the mass removal? See, simply, she may ask this question, but usually, actually, she means that you are going to remove the mass with some of the area around it, and this will be discussed with the consultant. So simply here, whenever she asks you anything about the treatment, you offer her the options, and you will tell her that the consultant will discuss with you. And after that, we can refer her, or she can ask for breast reconstruction to be offered to her. Okay? So this is the station of the DTIS. The only change here in this station is that from the other breast stations, you have to break it bad. Why? Because actually I'm having a clue to the diagnosis here. If you're having a clue to the diagnosis, no, actually, you are not only having a clue to the diagnosis, you're having the diagnosis itself. That's why now you can say very boldly that you're having a condition we call ductal carcinoma in situ. Has anyone got any question? Okay, Dr. Messi, no problem. No problem. Take your time and mind the road. How was your exam, by the way, Dr. Messi? The IELTS. I forgot about that. How was your exam?
Brother, the speaking part is on the 2nd May, and the writing, listening, and reading will be on the 4th.
On the 4th?
4th of May.
Oh, so you are traveling just ahead of the exam.
Yeah, because it's far away from my place. I have to go to Delhi, the capital of India.
Oh, you're Indian. I thought you were from Bangladesh.
No. So I have to go to Delhi.
Oh, yes.
Take my
Best wishes, inshallah. By the way, your IELTS is expired?
No. I have to get 7.5 in each domain for foundation year 1.
Oh, yes. Okay. You didn't take internship?
Yeah,
Oh,
I haven't done mine.
go ahead. Why didn't you take internship? Why didn't you take it?
It's a different story, brother. We'll talk some other time.
Okay. I appreciate your kindness and your care about the colleagues. Take your time, man, and watch the road, okay?
Yeah, sure.
Okay. So, you don't have what, Dr. Nigar? You don't have S script. The ductal carcinoma in situ. I will send it to you. I will send it to the WhatsApp group. No problem at all. Just remind me or text me after the chat, and I will send it to you. The ductal carcinoma in situ or in situ. And fibroadenoma as well. You will see it. But guys, these scripts are not for share. Okay, because these scripts, when someone shares them, they know that it's coming from me. Okay, guys. Fibroadenoma, Dr. Elvira. Fibroadenoma simply free mobile breast lump, freely. Yeah, I will send the notes only. Freely mobile breast lump, which is not attached to the overlying skin or the underlying structures, and small in size. So just it's like, how can I say, it's like a spot on the breast, just like spot, freely mobile and very easy and very smooth. And this is fibroadenoma. By the way, this can never be combined station because you cannot put freely mobile mass on the breast mannequin. So simply fibroadenoma is freely mobile mass on the breast. So it is fibroadenoma, and you will keep reassuring her that this is mostly benign. However, we will refer you to be seen by specialists to confirm that. What was your question, Dr. Islam?
Yes, Dr. Ahmed, I was asking about how they will put mobile masses in the mannequin.
Yeah. No, they cannot. I told you it's not combined. You know what?
Yes,
I told you the examiner will give you a paper full of findings.
Yeah. Thank you.
Yeah, Dr. Elvira, this is not a combined station. This is, you just verbalize the breast examination, and the examiner will give you a big paper full of findings, around like 10 or 11 findings. You will find all of them inconclusive. All of them are benign and all of them are smooth and simple.
On my day, Dr. Ahmed, the examiner didn't give the paper of result. Rather, he verbalized the result by himself. When I said I'm going to examine the breast lump, and then he gave the findings, all the findings. No paper, but I needed to listen very carefully.
Yeah.
What were the findings? Yeah.
Yeah, but you know, actually, what happens? What happens is that if it is like a recent mass which is really mobile, or a recent mass which is smooth, no change inside, nothing else at all, just I need to hear from the examiner one word. The one word is that if this mass is really mobile and if this mass is smooth interface.
Yeah.
These two findings can give me fibroadenoma. So very good for these notes, and that everyone should listen to that. Did you take your exam in London, Dr. Yasmin, or Manchester?
No, Manchester, and all the four descriptions about the lump was very clear.
Yeah.
Location, site, inside. It is located on the right breast, right outer upper quadrant. It is like sized measurement he gave, some 2 by 2 something. And then it is with the regular margins, mobile, okay, mobile, freely mobile, not attached with the underlying structure. There is no armpit swelling or lymph node enlargement.
Yeah, so nothing is conclusive, only the smooth mobile mass. The smooth mobile round mass. This is it.
Then I thanked, and I just made a mistake, I know now.
What is a mistake?
I didn't disclose the fibroadenoma to my patient as my nature is that to describe it, to explain it, and then last question I did a blunder that she asked, so today you are not doing anything? I said, no, I'm going to do ultrasound today.
You can't.
It was not my duty.
Yeah,
I can't. That is the thing I know.
Yeah. And that's why I told you that this station is not present in many scenarios or in many academies. Okay? Mind this station, please. And it's very easy. Do not waste it. One other station.
Because I already said that as your aunt has that, to rule out other cases, I'm going to refer you to the breast clinic, and where they will do triple assessment. I said all these three things, like they will do take detailed history, detailed examination, they will do ultrasound as you are young, and after that, if needed, they will take the biopsy. All the triple assessment I told, and even then at the last when she asked, so today you are not doing anything, and then I said, okay, no, today I am going to do ultrasound. So maybe that's why I failed that decision.
Simply, you can. I have a good idea. If someone asks you this question, definitely you know why she's asking you this question. So
Yes.
today you are not going to.
I'm going to send you to hospital today.
No. Wait. So today you are not doing anything.
Yeah.
What does this question reflect?
Like I did already, history, physical examination.
No. This question reflects that she is quite worried and she needs something immediately or urgently.
Yeah. The title of the station was urgent referral.
Yeah. So Dr. Yasmin, so simply, you're going to ask him, may I know what's worrying you or what's bothering you? Doctor, I'm really worried about cancer. Reassure her again, and then tell her that we are going to refer you to the hospital immediately, right now. And the hospital will definitely give you an appointment to be seen within 2 weeks. And do not assume, but this was never asked so far. But if she asks you, doctor, but I need them to be seen by me right now, I need to be seen by them right now, I need an appointment right now. So simply tell her that, again, reassure her you don't have anything suggestive of cancer. However, actually what they do, they usually put you or give you an appointment, and that's why you need to be seen after 2 weeks by a specialist. It usually takes time. It's up to the hospital. I mean, all the British patient, all the UK patient know that the appointments may take time, or the appointment may take a little bit time. She will never ask you about something which is not your job. Your job is to refer her because you're in GP. You're not FY2 breast clinic.
Okay.
So
today I'm sending her to the hospital. In hospital, what they will do today, what they will do?
They will just give her an appointment.
Okay, they will make that. Got it. Okay.
So simply here, the hospital will contact her, and they will definitely give her an appointment after a while. And what will happen? Simply, hello, there is a noise.
Doctor, Dr.
Yeah.
Ahmed, I'm sorry to disturb. You know, it doesn't work this way because they don't send today straight away you to the hospital, even if I'm worrying dying. Because I went myself to the GP and I said, I suddenly found the lump in my breast. Probably I was depressed then. I went and said, this is probably cancer. You have to do something. And she said, okay, I will refer you and you will be seen within 2 weeks. And that was a lie. I got the letter, I was seen within a month. But it doesn't work that way, I think. She can't send that the same day to the hospital.
I just got it from the NHS website. You
Okay,
refer,
okay.
yeah,
That's it.
yeah, because actually you refer to the hospital and the hospital will be giving you an appointment. Actually, what happens,
Hello.
Dr. Elvira?
Hello.
Just let me add one
I
thing,
just
please. Dr. Nigar, please let me add one thing, and just anyone who needs to talk, you can ask.
sorry.
Okay, no problem, because this point is really confusing to some people. Well, listen, simply what will happen, they send you to the hospital. Most of the hospitals will contact you. Why? Because you know the transfer or the referral usually is done online, like online refer or via the system, via the NHS system. So what you're going to do, you're referring her to the hospital system. The hospital will contact her number and they will give her an appointment within 2 weeks. So now he did the referral, but they did it online. I mean, it's not like physical reference. They didn't refer her like herself. They just refer her case. So are going to
Okay,
refer.
then.
Yeah.
It would be probably safer to say that I'm referring you today, and you'll be seen very soon. Yeah?
No, I will refer you to the hospital and they will give you an appointment within 2 weeks. Very simple.
Okay.
Because this is, listen, for any breast problem, usually, you know what, even if she is diagnosed, if she has high possibility of cancer, still, you will refer her within 2 weeks. She will be seen within 2 weeks.
Okay, thank you.
You're welcome.
Sorry.
No problem. That's fine.
And Dr. Ahmed, now I believe that you have to reassure it. This is benign condition, fibroid adenoma. There is no need of urgent referral. I believe my answer should be this.
No,
Yes.
actually, listen, even if the condition is serious, you know what to do? They will give her an appointment within 2 weeks because, you know, the breast cancer will not spread. I mean, it's not aggressive within 2 weeks. It will not happen within 2 weeks. This is how it works. I'm not sure about, I'm not sure about their system, but what happens and what I read is that for any possibility of cancer, even the breast, they give an appointment within 2 weeks.
Yeah, 2 weeks time is common.
Yeah. So, next station is one of, yeah, Dr. Nigar, I'm sorry, yes, tell me. I'm sorry,
Yeah, I
forgot.
just want to tell, do you know, they refer same day, but what happened, this referring work is gone by like admin people. That's why I think she got the appointment after 1 month. Normally it is within two weeks, because I do work there. I know it is whenever they need to refer any patient, they feel anything, they want to refer, they refer actually, and admin people do this referral work. If admin people delay the work, then they get the appointment late.
Yes. So it's definitely within 2 weeks.
Yeah, it's within 2 weeks.
Dr. Manisha, say on the mic, say what you say.
Hello. I had this station, and so she asked me when can I see the specialist. So I told her, since you are having like not suggestive of cancer as such, we don't need to refer you urgently. So then she asked again, like, so when exactly can I see the specialist? So then I told, like, we'll refer you. So they'll try to see you in 2 weeks, most probably, like kind of like that. And luckily I got 12 in the station, so I think that may be right.
Yeah, so they will see you in 2 weeks. And the problem is that, okay, again, what happens at your GP appointment? The GP will look and examine your breasts. If they are not sure what's causing the lump, they will refer you to the hospital or breast clinic for further tests. These tests usually show that the lump is not cancer. What happened at the breast clinic? the breast clinic, you will have examination and scan and biopsy again. So this is what's written on the NHS website. Again, regarding the period or regarding the time frame, it's not written here 2 weeks, but I read it somewhere. I just need to check it again. But even in some other station, by the way, there is a breast lump in the combined station, breast lump, and you're not sure about the cause, but still you'll be giving here an appointment within 2 weeks. So I'm pretty sure that for any case, usually, she will be referred within 2 weeks.
So, Dr. Ahmed, I just learned now after looking into the feedback, GMC feedback, that you need to give the reassurance to your patient because you got it that this is benign condition. There is not urgent need. However, I'm referring you to rule out other causes, and you have a positive history of breast cancer in your aunt. That's why I'm giving you the referral. It might take 2 weeks of time for the breast clinic where they will do triple assessment, but this is not something urgent which should be verbalized from my mouth from as a FY2. Like that. That's the point I got now, that the word urgent, word urgent is to be addressed here. There is no urgency. That is the point I learned now so far.
So you're just going, so you refer her to the hospital, and the hospital will give her within 2 weeks. You want to say that they will give you appointment within 2 weeks because your condition is not something serious.
That is the thing. I have to reassure it by saying that this is not something needed for urgent referral. I have to acknowledge it.
Yeah.
And reassure the patient, because the title of the station is patient
Urgent
came for
referral.
urgent referral. Yeah, patient came for urgent referral. So I have to recognize it and acknowledge her that no, there is no need of urgency by reassuring the diagnosis.
Okay. So this is a point, but here in this station, actually, you have to mention to her from the beginning that this is benign, actually, by saying fibroadenoma.
I think this is
okay. So next station is still not present here in your notes. It is earwax. No, it's not earwax. This station, there could be a discrepancy about this station between the academies. Some academies mention something and some other academies mention other thing. Actually, it is otitis externa, neither earwax nor the barotrauma. It is otitis externa because the photo that will be given to you will be the photo of otitis externa. I'm trying to find it for you right now, the exact photo which will be sent to you in the cubicle. Wait, I'm just trying to find it out. Give me less than 1 minute. I'm trying to find it for you guys. Okay, check the WhatsApp group right now. This is a station that came so far. This is a photo that came so far. Can anyone tell me their opinion about this station or about this photo? What you see? So what's your opinion? Can anyone tell me that? Okay, Dr. Ofodeli, Dr. Ofodeli, are you here?
Yeah, I am.
So Dr. Ofodeli, did you see the photo?
Yeah, I saw it.
Okay, Dr. Fodley, what's your opinion here? What do you think? Dr.
I
Elat
think
looks
there's a
scared.
lot of I think there are a lot of degenerative changes occurring here.
No, okay, let me tell you something. Her complaint is that she's having, you know what, she's having sometimes ear pain or ear, like, I can't say pain, it's just, sort of discomfort.
Okay, okay, okay,
Like,
okay,
she is like dull aching discomfort in the ear, okay? And,
okay,
okay, let me explain to you what is the station exactly. So let's start from the beginning. Dr. Ofodoli,
okay,
she has presented to the clinic, okay, to the GP clinic because she's having some problems in her ears,
okay,
okay? So actually, she's showing you through the station that she is not listening or she is not hearing you properly. So which questions to ask here in this station? I mean, I'm telling you the presenting complaint, doctor, I have problem in my ear.
okay. First of all, ask which ear are you talking about?
I'm so sorry to hear that. What is the problem exactly? I told you I have a problem. Why didn't you ask me what is the problem exactly? Doctor, I have a lot of wax in my ears and I cannot hear properly. Now ask me.
Okay. I'm so sorry that you've been undergoing this for a while now. Can you tell me more about this?
Doctor, what you want to know?
Well, I want to know which particular ear do you feel that
Left side.
your
Left side.
left, and also how do you mean by you have wax in your ear?
Doctor, actually, I noticed that I noticed that there is some like when I used to clean my ears, I found a lot of wax when I was using the cotton bud exactly.
Okay, and since then has it been progressively getting worse?
I think so, doctor.
Okay,
And my hearing is even getting worse.
okay. At the moment, are you comfortable? Can you hear me very well now?
Just I would be thankful if you raise your voice, doctor.
Sorry, that I will do that immediately.
So simply you'll ask her about she's having hearing problem. So ask about the hearing problem in separate and in the wax or for the wax in separate, right?
Yeah.
Very simple. And one question about the wax, I mean for the ear loss or for the hearing problem, you'll ask her when did it start, how did it start, has it changed, and which ear, of course. And then for the wax itself, for the wax, how did you notice the wax? This is the most important question for the wax. And since when it started, and what about the amount? Have you noticed any something strange with the wax? Like, I mean, in terms of the amount? No. Okay. So, what could be the associating symptoms that you're going to ask about? I mean, after now elaborating the hearing problem and the wax itself, what is the next question?
Ask about pain.
Yes.
Any redness or swelling around the ear?
Exactly. So why didn't you ask open question first, Dr. Akuli? Is there anything else?
Okay.
Yes, doctor, I have some ear discomfort. Tell me more about it. Doctor, it is in my left ear. She will give you like a left ear and it started 10 days or 2 weeks ago. And how did it start? Doctor, please mark this word. Doctor, it started after the holiday, together with my hearing problem. So now she's having ear discomfort or ear pain, and she's having ear problem, and she's having a lot of wax. What do you think? Don't you
Possible
think?
of travel.
Huh? Tell me.
Because she gave a mention of she made mention of holiday, so
Yeah.
travel history is important here too.
Very important, and swimming as well.
Yeah.
So now she will tell you, doctor, it started right after my holiday and it's getting worse, and it's just dull aching pain. She definitely tried some paracetamol and it didn't help her. So now she's having the three things. Anything else? Like what, doctor? Like, do you have any blockage in the ear? Yes, doctor, I noticed that there is fullness in my ear. So now ear pain and fullness and wax and hearing problem. Why I'm asking about the blockage or the fullness in the ear? Because definitely if there is a wax and if there is an ear pain, definitely anyone would feel the ear is full. You know, if you have like some sort of inflammation in your ear, you will find that or you feel that your ear is full. So ask about if there's any fullness in the ear. What are your differentials here? I need to ask about the ear problems, like for example, is it charge, any redness or swelling, like Dr. Okudri asked. So number one, otitis media. Number two, do you have any ringing in your ear? Okay. Do you have any itching? So itching and ringing are very important. Okay. Also ask sometimes about fever. So again, your differentials, otitis media and other tinnitus problem, like maybe inner ear problem. And you can also ask about the itching, because itching is one associating symptom of otitis externa. So again, otitis media, itching, otitis media, and tinnitus. Those are your differentials here. Please do not forget about the fever and the otitis media. Ask about the fever, very importantly. Fever to be asked in any ear or any infectious. If you are confused or if you think without any infection, please ask about the fever. Past medical history, nothing significant at all. Like you can ask all the questions of the past medical history. Very important to ask about the allergy. Why in any ear problem you can prescribe antibiotic at any time. So please do not forget to ask about allergies. Lifestyle history. Ask about smoking, alcohol, physical activity. Very enough. Here's some set of questions not to be missed. So now we say the DDs. Now the important questions not to be missed. What are the important questions not to be missed here, Dr. Afrodali? Some specific questions not to be missed in any ear station. I told you before, all of you. What do you think? Okay, let me say that because I need to save time from now. The most important questions are the travel history and the swimming and cleaning with the earbuds. So travel history and swimming and cleaning with the cotton buds are very important here to ask. Why? Because if she traveled recently, especially as a flight, there could be history of barotrauma. Swimming increases the chance of otitis externa. Cleaning increases the chance of otitis externa. So swimming, cleaning, and travel. Okay. Which examinations to do? Here, please, I need all of you to write in your notes that you need to do full ear examination. Full ear examination, inspection, palpation, including tragus test and otoscopy. Inspection, palpation, including trigger test and then otoscopy. What happens is that the people who forget to mention the tragus test, they fail the station. Can you imagine? Just if you forget to mention the tragus test, you are going to fail the station. So inspection, palpation, including tragus test, and after that, after the tragus test is negative, now you can do the otoscopy. Never, never, ever go for the otoscopy if the tragus test is positive. How can you insert a device in someone who's already tender and in pain? So you cannot insert or introduce the otoscope if the tragus is already painful. After that, you are going to do cranial nerve 8 examination, which is including René and Weber. So ear examination and cranial nerve 8 examination, René and Weber. And the examiner will show you the vitals. The vitals are quite normal, but the problem is that the ear, you see the picture? The picture is as you see, as I told you or as I sent you on the WhatsApp group. Let's explain this picture. This picture simply shows that she is having some wax. That's why the people will see that or will say the diagnosis is earwax. However, now it has gone beyond the earwax. You see now the ear canal is congested and swollen. See how red and how inflamed? Definitely, This is because of the infection of the earwax. This has caused some infection in the ear canal. So the accumulation of the earwax, like any obstruction, creates a good bug or good media for the bugs to grow, and now that's why she has developed the otitis externa. So you are going to tell the patient you have a condition we call acute otitis externa. What is that? It means that inflammation in the external ear, which is the outer ear canal. Okay, how did I get it? Simply, you will tell her that this case, actually in your case, it could be because of the accumulation of the earwax. The ear canal is narrow, and when something is on the way or when something blocks it, it creates good media for the bugs to grow. Like any obstruction in the body, blockage leads to growth of bug, which creates good media for the bug. So, the accumulation of earwax is one thing. Number two, swimming. She has swum. She has swum recently. So, actually, the accumulation of water itself can, inside the ear, can lead to the growth of the bugs. This is number two. Okay. Sometimes, if she tells you that she is using cotton buds to clean the ear, this can be also one reason, because this is a scratch. Scratch causes like irritation, okay, which damage the skin, and this causes inflammation. So three reasons could be the earwax accumulation and the swimming lead to accumulation of water, and the scratching or the itching can be another cause as well, because it damages the skin and it leads to inflammation. What are you going to do for me right now, doctor? Okay, now simply the treatment for the otitis externa. Ear drops. They are called acetic acid drops. What are these ear drops? Dissolve the earwax. So they are very simple. Besides some antibiotic ear drops as well. Why antibiotic ear drops? To clear the infection. These ear drops contain antibiotic and steroids. Why steroids? To reduce the inflammation. So again, wax dissolving drops, acetic acid drops. Number two, some ear drops which contain a mixture of antibiotics and steroids. Antibiotic to clear the infection and steroid to reduce the inflammation. Number three, we're going to give her painkillers for her ear pain. Okay, so in this case, actually, after giving her these medications, we can also consider some ear cleaning. Ear washing, this clearing or this ear washing can be done either in your GP, or it can be even done by the patient in her home, or can be done by the specialist. So we can consider like syringing or cleaning of the ear. Okay, why? Because it dissolves the wax and give more the chance to the drops to enter the ear. So 4 lines of treatment. Number 1, dissolving drops. Number 2, antibiotics and steroid drops. Number 3, some painkillers. Number 4, ear washing or ear cleaning. You can also refer her to specialists for the cleaning as I told you, if you wish. If she asks you, doctor, how can I prevent this from happening again? To prevent this from happening again, just give her some lifestyle advice, like do not clean the ear with your hands or with cotton buds at all. This can damage the skin, and this also can push the wax inside. Number 1. Number 2, regarding the water, if she's going to swim, better put earplugs. Why? Because the entry of the water will accumulate inside and it will create a good media for the bugs to grow. When she is taking shower as well, please not try the shampoo or the gel to enter into her ear. Why? Because simply the systole can cause good media for the bugs to grow. So if possible, in this case, during shower, you can place a cotton wool soaked in paraffin in the ear. So during shower, she can place cotton wool soaked in paraffin in the inner ear. So this is the thing. Can we irrigation if the ear is inflamed? Dr. Zaid, you are just going to do the irrigation to dissolve the wax itself, because the wax itself is the cause of the inflammation and it will not give the chance to the drugs to dissolve or to enter inside, to penetrate. No investigations here. This is just clinical diagnosis, Dr. Kashi. How to do investigations when the road or when the path itself is blocked? I mean the ear canal is blocked and there is inflammation. You cannot introduce anything. This will be inhumane. It will be very painful. So these things to always to consider here. And she will ask you sometimes actually also you will tell her that I told you about the cotton buds, the earplugs, and I told you about the swimming, avoid swimming, and the how can I say, and also do not let the water enter inside. She can also consider the dissolving drops, especially when swimming. You know, some swimmers consider taking acetic acid drops, dissolving drops during their swimming session to prevent the wax from accumulating or the water from accumulating and creating more wax. Warning signs here will be that if your symptoms did not improve or if you develop any discharge from your ear, come back to us, the otitis media. If the symptoms do not improve and if you develop any discharge from your ear, come back to us. If she asks you, can I use earbud to clean my ear? You would advise her not to do because this can push the wax inside and this can irritate sometimes the lining of your ear. Okay, give me 1 minute, guys. Hello? Excuse me, wait. Excuse me, guys. So this is a station of the ear, and please, you will say otitis externa. Under any condition, say otitis externa. Do not think. I do not need any of you to think about that. Okay? Many people said earwax, other people said barotrauma, others said whatever. No, it is otitis externa. And I showed you the photo which will be sent to you, which will be given to you by the examiner. Okay? So please do not be too smart in this station. Okay? Okay. Let's move to one station, which is the letter after sigmoidoscopy. Letter after first of all, so far, you know, when I told you before, when you are finishing some stations, I may give you, like, we can ask after some set of stations, but please do not ask instantly. I mean, if anyone has any comment, please ask in the end. Today is already long. We still have to cover the OBG, so that tomorrow we will finish the pediatrics. Okay? So, in this case, simply, the woman is referred to you. She had sigmoidoscopy, and she is here because she wants to discuss some few things with you. Okay, so she has been referred to you for colonoscopy, and why she has a colonoscopy? She has undergone this colonoscopy because she had bleeding from her back passage, and the sigmoidoscopy, she had sigmoidoscopy, and sigmoidoscopy showed that she's having rectal polyp. And the biopsy, I mean the sigmoidoscopy, usually we take biopsy within the sigmoidoscopy. It showed that the polyp is benign dysplasia. The gastroenterologist has seen the patient and decided that it's important to do colonoscopy. So she is going to have colonoscopy after the sigmoidoscopy. So now she's coming to you because she's going to undergo colonoscopy. She's having some concerns about the colonoscopy. You are the first doctor to talk to her about that. When you enter the cubicle, you will find that the referral letter. Referral letter written to you by the gastroenterologist. It says that she was complaining of rectal bleeding. I performed sigmoidoscopy and I found rectal polyp. Biopsy showed benign adenoma. We referred her to do colonoscopy. Okay. So now you are going to talk to the patient. How can I help you? She is usually concerned about the camera test, which is a colonoscopy. She would tell you, why would you want to do the camera test for me and I'm already diagnosed? I don't understand really. Please tell me why the camera test again. Reassure her until later I can see that you're concerned. We are all here to help you and address all your concerns. For that, I'm going to ask you a few questions if you don't mind. Now, as we said, number one, reason for attendance. This is number one. Why did you do the camera test? The first test. She told you that, or she will tell you that I had bleeding from the back passage. Tell me more about it. She will tell you, doctor. She will give you a history of a few weeks bleeding, and she had many episodes, and she does not have any bleeding so far. It was just like a small amount of the bleeding. And pure blood. Pure blood is usually toward rectal polyp, right? So, and it was for bright red blood as well. So pure blood started, or bright red blood started a few weeks ago, and there was no change in it. That's why she came to the hospital and she did the sigmoidoscopy. Now you can ask 2 or 3 more questions, like for the DDs. Have you noticed any change in your bowel habits, like any constipation? No. Any diarrhea? No. Any abdominal pain? No as well. So the DDs here are maybe some sort of infection or IBD, some sort of infection or IBD, I could ask about them. Like IBD is any change in the bowel habits, any fever or flu-like symptoms, and as well, the other differential is the cancer. You're going to ask her about the weight loss and maybe shortness of breath or loss of appetite. Those are the two questions to be asked here, or the two differentials. Now, I mean, if you want to ask about any blood disorder, any these things, you can ask. But I'm just telling you to cut your time short here, because this is sort of counseling station. This is not history based. She's already diagnosed. She has some concern regarding something, which means that it is counseling station. So now we are going to ask some few questions about the lifestyle. Before, after the lifestyle, you're going to do examinations. Which examinations? Everything, including abdominal and perirectal. Why perirectal? Because of rectal polyp. Why abdominal? Because this is bowel complaint. Okay. Now she will ask you sometimes, doctor, why are you asking me these questions? I'm already diagnosed. Please tell me the colonoscopy. I told you before, if anyone insists on knowing their test result or knowing their concern, I mean, now in the beginning you told them, please bear with me. And if they repeat it in the middle that doctor, don't ask me anymore, I need to know my concern, now move to her concern. She gave you the chance to ask her once, or second time, do not waste your time and move to the concern directly. Now, she will ask you, why should I have this camera test? Now you explain to her that sigmoidoscopy is the first thing, and now we are going to do colonoscopy. Do you know the difference between them? Sigmoidoscopy simply is to visualize the rectum and the inner canal. Sigmoid and rectum and inner canal. So this is for the lower part of the bowel. But the colonoscopy, usually we use it to visualize what's beyond this. I mean, like starting from the large intestine and so on. So sigmoidoscopy was for the lower part, for which we found the rectal polyp in it. What is polyp, doctor? Polyp is just a small growth, benign growth most of the times, like in your case, which happens or which pouches out, pouches inside the wall of the intestine or the wall of the bowel. Okay. So now what is the difference again? What is the difference between the sigmoidoscopy and the colonoscopy? I told you, difference is that the sigmoidoscopy looks into the rectum and sigmoid colon, okay, while the colonoscopy looks or assesses the rest or what's beyond this in your colon or in your bowel, and it can be pushed up till the cecum. So the colonoscopy can be pushed up till the cecum, by the way, and we can use it as well to take sample. Doctor, but I was already diagnosed. Why do you do it again? So this lady is trying to show you that she has some concern regarding the colonoscopy. May I know, do you have a specific concern? Yes, doctor. Actually, doctor, it was very stressful. I don't want to go through this again. So now she is saying about the stressful, right? Reassure her and tell her we're going to numb the area and we can give you mild sleeping medication as well. Like the endoscopy, if you remember. What is a mild sleeping medication, by the way, if anyone asks you? Simply, it is just like sedative, normal sedative. So it's not anesthesia, it is just sedative. So again, we can numb the area, we can give you mild sleeping medication, like the colonoscopy exactly. But doctor, I am already diagnosed. What is the problem here? We need to do the colonoscopy for two reasons. Number one, because the polyps, if there is polyp found somewhere in the body, there is high chance of associated polyps elsewhere. For example, if the polyp is in the rectum, there is high chance of the polyp to be present as well, or other polyps to be in the colon. So simply, we need to do it to see if there's any polyps elsewhere in your colon or in your bowel. And if we find, we can take a sample using the colonoscopy or the colonoscope. Okay. Doctor, how will it be done? Simply the procedure. I told you before, any procedure, speak about before, during, and after. Before it, she needs to empty her bowel. Why empty? Because you're going to insert something in the back passage. It needs to be giving a clear image. So for a clear image, she needs to empty her bowl. For that, we are going to give her some laxatives before the procedure. So this is before the procedure. Number one, laxatives to empty. Number two, she needs someone to be accompanying her to the hospital. Why? Because actually we will need someone to accompany her after the procedure. I told you we'll be giving her mild sleeping medication. Any sedative can make you feel dizzy. So in any procedure, someone must accompany the person because they are more likely to feel dizzy after the operation or after the procedure. Now this is before. What's during the operation or what's during the procedure? Simply, she will be lying on the side of the couch, most probably the left side. We will push the end of colonoscopy into the back passage, up into the colon. Okay, so simply introduce into the back passage, move up the way through the colon, and there will be camera attached to it to visualize what's going on. Sometimes they can introduce air. You know why do they introduce air into the colon? To make the field more clear and much easier to see. So sometimes you can introduce air, which make her feel bloated sometimes. Okay, so no need to be embarrassed about that. This is just temporary. So they take a sample after that, and the sample will be sent to the lab. Usually it takes 20 to 30 minutes. Okay, and usually it doesn't have side effects, just sometimes uncomfortable, exactly like the endoscopy. The only difference between the endoscopy and sigmoidoscopy in everything is that we can introduce air in the colonoscopy. Why? To make the field easier to see, because this is a bowl. Bowls contain many gases, many feces or many stool, so we need to clear it. And we need to give laxatives as well before the procedure. What are the side effects? Again, like any procedure, sometimes like some pain, usually it's temporary, some infection, some bleeding, exactly like the endoscopy in everything. No draw in this station. How can you draw it? If you want to draw it, you're just going to draw the large ball, like the colon. Yeah, I mean, if you're going to draw, you're just going to draw the large ball, the colon, and you're just going to see how we insert it. Like, I can't insert. Okay, just the large ball, like from first year medical school. You know how you draw the large ball, and in the large ball you introduce the tube, or sorry, the flexible tube, the colonoscopy, up the way to the bowl, up to the cecum. It's very enough to say that this mainly is introduced beyond your sigmoid colon, for which you had the sigmoidoscopy. Doctor, is it cancer? May I know why you think so? Doctor, because I have bleeding. Okay, actually the reason here, actually let you assure here that you don't have any symptom, the polyp was benign. However, we need to do the colonoscopy. The aim here only, the aim is to exclude other polyps elsewhere, and as well we need to exclude other conditions like any other abnormal growths. So the aim of the colonoscopy is to detect any further polyps and to exclude any other conditions. So that's it. Colonoscopy here is done for two reasons: for diagnosis or exploration of the ball for any other rectal polyps, and also as well to exclude other causes. Okay, this is a sigmoidoscopy, definitely. So the aim of this station is to convince the patient that we are doing the colonoscopy, just to confirm that there is nothing else in the ball. Okay, let's move to the next station, which is a wound infection. Wound infection, some people may consider it like as a sort of Breaking Bad, as a sort of like angry patient. This is sort of Breaking Bad news, or sorry, not Breaking Bad news. This is sort of angry patient. So here in this station, let me open the task for you because I need to give you the full task because there is difference between both tasks here, and please mind the difference between both tasks because this is the core of the station. Here the task is the core of the station. Wait a moment. Okay, you are FY2 working in surgery department. The patient is 29 years old female patient. She has undergone operation to remove cyst in the leg 2 weeks ago. So she had the operation 2 weeks ago. 3 days later after the operation, she developed wound infection at the site of the operation. So just 3 days after the operation. Now the chance of catching the infection from the operation, I mean the chance of the infection being a complication of surgery is high. Why? Because it's just 3 days after the operation. Just 3 days mean that usually it's because of the infection itself, because of the operation itself. She was admitted and she received IV and oral antibiotics. So she received antibiotics and she has been treated and tested. Now she's here to talk to you. She has got some concern. Special note, she's angry. You know why she's angry, guys? She's angry because she knows that she has got this infection from the hospital. That's why she's angry here. So now, when you enter the cubicle, she'll ask you, I need to know why I had this operation, why I had this infection after my operation. Please tell me. Now you reassure her, I'm here to address all your concerns and talk to you about that. But if you don't mind, let me ask you a few questions. Again, you will assess the reason of the visit, reason of visit number 1, number 2, current conditions, number 3, past medical history, number 4, lifestyle, number 5, examine, like any station. Okay, reason of the operation. She had an operation to remove cyst from the leg or some cyst in the knee. When was that? 2 weeks ago. One question to ask here, very important. Did you stay in the hospital? She'll tell you, doctor, no, it was daycare surgery. You know what does this mean? This means that the chances of infection are lower. When someone stays less in the hospital, the chances of infection are lower. However, here she probably got the infection from the operation itself. So here you will ask her actually, okay, she told you I stayed in the hospital for 1 day. How did the operation go? Was there any problem after the operation? No. Doctor, everything was fine till 3 days after the operation. What happened? I developed swelling at the operation. So now you ask it about the current or the past visit or the past treatment. And she told you that after the operation, 3 days, she developed swelling at the site of the operation. And it was very painful and it was very difficult to me to walk. So when someone is having swelling, we need to ask about any pain, any redness, any discharge, signs of infection simply. Okay, so here she has got these symptoms. Probably she got wound infection. How was it managed or what was done to you in the hospital? Doctor, they admitted me and they gave me antibiotic through my blood vessels. And after that, I received tablets for 5 days. I was stuck in the hospital. I was not able to work. I was not unable to take care of my kids because I was here. So she has got infection after the operation for which she has been admitted in the hospital for a few days to take antibiotics and oral. Now, I elaborated the reason of visit. Number two, move to the current condition. How are you feeling right now? How is the pain? How is the swelling? How is the redness? I'm fine. So now she had nothing. Past medical history. What are the important questions to consider here? You know the things that can precipitate wound infection, like what? Diabetes, like taking antibiotics. Those are the two important things not to miss in the past medical history, diabetes and antibiotics. Please do not miss this in any surgery station. Okay, now move to the lifestyle. Very important lifestyle to ask about smoking and physical activity as well. Physical activity after any surgery, early physical activity can precipitate the infection. Please do not forget to ask about the lifestyle. What about the job? Ask about the job as well. Why? Because returning to the job earlier can precipitate the infection as well. So what did you do for a living and when did you go back? Okay, usually, you know what happens here in this station? She is working in an office and she did not return to the work, which means that definitely she has no reason throughout the whole history. I mean, no personal reason for the wound infection. Definitely here the wound infection happened because of the hospital. Do examinations here. Which examination? I need to look at the wound. Now the examiner will tell you nothing because probably now from the history you know that there is wound infection and it happened shortly after the surgery. So definitely it's because of this problem, that surgery itself. So now, doctor, tell me please, how did I get this infection? Well, you will tell her that usually wound infection has many causes. However, in your case, it could be due to the operation you had, and it's one of the common complications. So now you will disclose to her that this is a complication of the surgery. So, doctor, how did I get it? Now she's concerned. Why? Because she thinks that the surgery is the reason. You will tell her simply that I know that it's frustrating, but you know, one of the complications of the surgery, one of the known complications of surgery is having infection. However, we took all the necessary precautions. However, even if we take the necessary precautions, there are always some like infections or bugs in our skin. And they can cause an infection to us, especially when we are not strong, like especially during and after operations. And that's why, despite all the precautions, we cannot prevent them. So, reassure her that we take all the precautions. However, you know, due to the body low immunity during the operation and due to the already present bugs in the skin, these bugs can cause infection even no matter how much precautions we take. So, she will tell you, doctor, why wasn't I told about it? Here, actually, her problem is that she was told, but she was not told in details about it. You know, simply, we do not tell in details the thing that we do not expect. So your colleague did not tell her about it in details. Why? Because actually, you explain more about the possible complications. However, here in her case, like for example, the cyst, simple cyst, you do not expect infection to happen. because we take all the precautions from happening. So this is the only reason. So he did not explain in details because this is not a complication we expect to happen because we take all necessary precautions to prevent this. She will ask you, so why didn't you give me antibiotic before the operation if you expect infection? Again, because here this is not a complication we expect because we take all necessary precautions, especially in this type of surgery. The chance of infection is very low. So, and the good thing is that we started the antibiotics right after your symptoms started and you are fine right now. I'm really sorry for what happened to you. So we do not prescribe antibiotics because we do not expect this complication usually, because we take all the necessary precautions. Now, she will ask you, doctor, does these things happen a lot in your hospital? What's your answer, Dr. Zaid, when she asks you this question?
Well, this is difficult actually. No, no, I don't know. I forgot. Yeah, this is, I forgot to know how to reply this for this question. But you want to yeah, you want to write or document this in this form, right?
What do you think?
Well, this complication might happen, but actually, I don't know how to write for this question. Yeah. I'm sorry, doctor.
What's wrong? Is there anything wrong with this thing?
I think with me wrong? No, but I forget how to reply for this.
No, it's fine.
This kind of
don't give up. Don't give up.
Yeah. I'm starting, but does complication happen a lot? Well, I should reply to her with I don't know how to reply actually.
Okay. Listen, Dr. Zaid, in any surgery issue, you do that. You send to the MMM, triple M. Triple M is called mortality, morbidity, beating. This is for the surgical cases. I'm writing it to you. Mortality, morbidity, beating, triple M. What is the, incident form is for medical errors, but surgery problems are discussed in the MMM. What is this meeting? It is simply monthly meeting. Simply, let's explain simply. Monthly meeting in which all the consultants, surgery consultants attended to discuss the cases and the outcome of the cases that came in the hospital or the department this month, and the treatment given to these cases and the outcome of these cases. What do you mean by the root case analysis, Dr. Islam? Yeah, it's something like that. Something like this, exactly, yes. Something like that. So this triple M is just a meeting held by the consultants to discuss the cases that came to them and how did they treat it and was there any outcome or was there any like complications or not. But without disclosing the patient details. Why do they do this?
So how can I?
Huh?
No, yeah, they're doing this one for improving the quality of the and prevent future error.
Exactly, simple, like the instant form exactly. But only the difference is that it's held in the surgery cases.
So what should I reply in this if I ask this question again? Does this complication happen a lot?
Okay, so now let me tell you what we do. We discuss it usually, or our consultants will discuss it in the mortality morbidity meeting. Do you want me to tell you about it? Now explain it to her, and the aim here is to prevent these from happening again. Still, she is not happy and she wants to complain.
She's not happy and she wants to complain. We can offer for her the pulse.
Yeah, exactly.
Yeah.
So this is the sequence. In any surgery, post-operative, not all post-operative complications, just in this case, not this case only, sorry, the post-operative problems or any surgery problems, you can offer MMM or triple M meeting mortality morbidity meeting. Okay, this is how you can prevent any post-operative issue or anything, any like problem like this, like the wound infection in the next times. So this station simply is about it. You have only to pick up that this is simply because of that operation itself. Why? Because it happened only 3 days after it. She doesn't have any other risk factor. She didn't go back to work. She didn't smoke. She didn't have any other medical issue to increase the chance of the infection. Wait, guys, sorry. You have never heard about what Dr. Elvira, sorry? Okay, so now you hear. Because the instant form is usually regarding the medical errors. No, instant form is medical errors, but the surgery is MMM. Excuse me, wait for a minute, guys, sorry. Okay, so next station is again wound infection. But you know, can anyone tell me the difference between this one? I mean, this station actually, you're here FY2 and E. The patient is 50 years old. Patient, 50 years old patient, presented with pain and swelling in the operation site again. He had open operation for his right inguinal hernia. So he had right inguinal hernia and had open operation for it 3 weeks ago. It was an elect, so he had the operation 3 weeks ago. It was daycare surgery. The patient is angry. And by the way, there is a special note here. The post-surgical wound infection in the hospital is within the national guideline. I will write it here. The wound infection was a post-operative wound infection. Post-op wound infection is within national guideline. What does this mean? This means that the chance of catching infection from the ward is quite impossible. So here you will find that the guy has got this swelling and this problem. It started actually maybe 3 weeks, no, not 3 weeks, like 2 weeks after the surgery, like only a couple of days ago. So he had the surgery 3 weeks ago, and these problems started only a couple of days ago. What are the problems? The problem is that he's having pain and swelling and discharge. Symptoms of wound infection definitely. So he will tell you that this pain started like maybe 2 or 3 days ago and it's getting worse and it's increasing on movement. He tried some paracetamol for it and it didn't improve at all. And he's having swelling as well, and he's having as well sometimes discharge. You know, the yellowish discharge which comes as a sign of wound infection. What else I can ask? I can ask about fever and any redness. Very enough. If he asks you in the middle, I need to talk to the consultant, doctor, I need to talk to the consultant right now. Please tell him maybe the consultant is busy seeing other patients at the moment. Meanwhile, I'm here to address all your concerns. So please, if you have anything in your mind, feel free to share it with me. Past medical history. Again, the same question. But very important here, and by the way, I forgot to tell you in the previous session, is to ask, I told you to ask about diabetes, any antibiotics, any diabetes, any antibiotics, and about the lifestyle. Here also, and in the previous session, please do not forget to ask about any recent cough or constipation. Any recent cough or constipation. Why? These two things can increase the chance of straining and developing complications. Please, guys, no cameras are allowed. No cameras are allowed, guys. Again, no cameras are allowed. Dr. Yemi, I can see you. No cameras are allowed. Okay, so you're lucky, by the way, you're having like cloudy. Nigeria is cloudy right now. It's getting hotter here. Anyway, here actually you can ask about cough and constipation. By the way, this guy is having smoker cough. Not just smoker cough. He's just having sometimes not smoker cough, like not established smoker cough, but he's having the cough because of smoking sometimes. But he was not diagnosed with COPD. So now he's having one risk factor for the, one personal risk factor. No problem, Dr. Reeve, no problem, I was kidding. So one problem for the wound infection, personal problem. And you'll find that the surgery was 3 weeks ago, and it was a daycare surgery, and there was nothing at all. And he was taught very well about the care of wound. Okay, for any wound you have to elaborate it, or any hospital stay or any surgery elaborated like it. When was it? Outcome of the surgery. Hospital stay, how long did he stay in the hospital? And did he care for the wound or not? Those are the 3 questions to ask about for any surgery. Okay, now ask about the lifestyle, smoking, diet, alcohol. This guy is smoking, and he is a heavy drinker of alcohol, and he went to the work earlier. He went to the work area, and not only this, he is working in a construction company. So he went to the work area, and he's working in a construction company. You see, he's having many risk factors for developing the wound infection. This guy is almost having everything for the wound infection: smoking, and heavy drinking, and heavy lifting, and even he didn't respect the leave. They told him, or they asked him to take a leave at least for 3 weeks. So now examination, you look at the wounds again. Right now, from what you told me, it seems that you're having wound infection. Okay, doctor, but why did I have it? Here in this case, you are directly telling him that this is because of this. Number 1, many things. Number 1, smoking. Number 2, coughing that you're having. Number 3, you turn it to the work earlier than you should be. He will ask you, doctor, but I think it's from the hospital. May I know why? Actually, it's highly unlikely here from the hospital. Why? Number 1, it was a daycare surgery. When your stay is short in the hospital, the chance of getting an infection from the hospital is low. So it was a daycare surgery in his case. Number 2, he had the surgery or had the operation 3 weeks ago, and now he developed the infection only 2 days ago. So you think any wound infection can happen? If it's caused by surgery, can it happen 2 days only ago? No, definitely it will come only 2 or 3 days after surgery. So those are the reasons. Number 1, hospital stay. Number 2, the time of the infection. Okay, so now this guy actually sometimes can ask you one question. Doctor, but it means it's possible, isn't it? Now you will tell him, don't say impossible, just say it's highly unlikely. Highly unlikely. Why? Do not say impossible, just say highly unlikely. No, infections can happen for anything and from anything, but just say it's highly unlikely. Because this guy needs to focus or press over you. He needs you to say that it could be possible. No, just say it's highly unlikely. It's even like it's almost impossible. Doctor, again, does it happen a lot in your hospital? Is it happening a lot in your hospital? Okay, in this case, simply what you can do to the patient or what you can tell him. Okay, now the task tells you that the rate of infection is within the national guidelines. You know what this means? That this is not happening a lot in our hospital. So just say this because the task told you about this. What are you going to do for me now? When someone is presented to you with a post-operative wound infection, when someone is presented to you about wound infection, what you are going to do? Number one, painkiller, simply because of the pain. Number two, you're going to take swab from the wound, okay, and send it for culture. Number three, according to the culture results, you're going to start on IV antibiotics. And you're going to clean the wound properly. For that, we need to keep you in the hospital. So again, you will take swab, and according to the result, we will start you on IV antibiotics. With the IV antibiotics, we need you to stay in the hospital because we'll be monitoring or we'll be reassessing your wound, and we'll give you some painkillers for your pain as well. He doesn't want to stay in the hospital because he has to go back to work. Now you have to tell him, but we need to give you these antibiotics as drip. Also, as well, you are advised to have rest from your work. Otherwise, this wound infection will not recover at all. However, if you are really worried about your work, we can provide you with a sick note. What is a sick note? Simply to be paid for the days that he was absent. He will tell you, doctor, but I'm self-employed. Okay, so the self-employed means that he has no contract. He works on a daily basis. So just in this case, actually tell him that I'm sure your health comes first. I know if you do not stay in the hospital, your condition will be worse, and even your time of going back to the work will be more delayed. Okay, now he will accept that. So if he wants to complain, actually, now you can tell him that I'm really sorry for your experience, but I told you that's one of the commonest complications. However, let me tell you what we can do in this case. Now you will explain to him the mortality morbidity meeting, as we said. Still not happy? Now you can guide him toward the pulse. So simply what you are going to do to this patient, you are going to convince him that it's not because of the hospital. Okay? It's not because of the hospital, number one. Number two, you're going to keep him in the hospital to start the treatment and take some samples from him. This is very important, guys. So the samples here are to diagnose the cause of the infection and to start the antibiotics. And that is the reason for which we are going to give him in the hospital. He will usually not accept staying in the hospital because he needs to go back to work. You will advise him that we need you to stay in the hospital, otherwise your condition will be worse and it will not be resolved at all. He will accept it, usually. But sometimes he can tell you, I'm a single contract. You can tell him that I'm sure your health comes first. After that, he will ask you, does it happen in your hospital? You will tell him that the infection here is within the national guidelines, which means that it usually doesn't happen in our hospital. Doctor, I'm not happy. Now you can tell him about the MMM. Doctor, I want to make a complaint. So if he's still not happy, now guide toward the pulse. Has anyone got any questions so far regarding the post-operative wound infection station? Yemi, are you fighting with someone? Yemi, when you are fighting or when you are walking in the streets, make sure that your mobile does not open. Okay? So, let's move to the next station, which is a post-operative hemi arthroplasty. This is a post-operative hemi arthroplasty station. Simply, it is a post-operative care station. The lady is said to have hemi arthroplasty, and you're going to talk to her about the surgery and the preparation after the surgery. She's going to have hip replacement surgery, after which she needs to have, or she has some concern regarding what's next or what's after surgery. Okay, now please concentrate because I will be fast in this station. She will tell you, doctor, I had a fall and I had a hip fracture and I'm going to have an operation for it. The anesthetist has talked to me about the pain and surgeon talked to me about the surgery. And I'm a bit anxious, I'm having some concerns. Okay, so she told me that the pre-operative assessment has been done and the procedure has been explained. Now, your mission here is to address her concerns only. What's your concern so far? She will tell you, doctor, what will happen after the surgery. Usually after the surgery, what happens in any surgery? We shift the patient to the recovery room, and if everything goes smoothly, she will be shifted to the ward. Okay, the second question, when can I walk? We usually encourage our patient to start walking as soon as possible. Why? Because it usually prevents one of the complications and also improves the recovery. However, some patients may start walking even, some in the same day of the operation. So we advise our patient to start walking as soon as possible because walking here will improve the recovery and prevent complications as well. Doctor, don't you think it's a bit early? Don't worry, we are going to, in any patient who asks you about walking, always say that, remember from the ethics station, we're going to start slowly and gradually, okay? And we will give you a walking aid. Why, doctor, is important? Because it prevents against one of the most important complications, which is a blood clot. So don't you think it's a bit early? We're going to start like simply and gradually, and we'll provide you with a walking aid. What are the complications of this surgery? Okay, some complications like the pain, some other complications, I mean, like it's, this is, I told you before, this is like a hip surgery. So the chance of pain is high, the chance of damage to the surrounding structure is high as well, and sometimes bleeding and infection. But there are specific complications for this surgery because it's occurring on the leg. So blood clot in the leg is high. And usually the anesthetist or the surgeon, they talk to her about the other complications like the pain. So now her concern is that she needs you to talk about the blood clot. So now again, you explain the complications, and would you like me to tell you about them? She will tell you, doctor, your colleagues have explained to me the pain. I need to know about the blood clots because one of my friends has got blood clots after surgery. So now you will tell her, you reassure her that don't worry, we will try our best to prevent that. Okay, now better do not assist or do not address her concern directly. You know what you should do here? I recommend that in this case, you ask her a few questions to see if she is at risk of developing the blood clot or not. Now ask her, have you had any blood clot before? Are you diagnosed with any medical condition? Any family member with, you will take past medical history very briefly. Any family member with any blood clot in the past? Do you drink alcohol? Do you smoke? Usually she has nothing conclusive. Okay. So now you will tell her that it seems that you do not have any risk. However, this can also happen after as a complication after surgery. For that, we are going to take the precautions. We are going to start walking as soon as possible. This is number one. Number two, we are going to inject some blood thinner to reduce the risk of stroke. Number three, we will give her support stocking. This stocking prevents the pooling of blood in the leg. How long will I be in the hospital? Usually the patients will, it differs definitely when someone asks you about how long, this question, how long, should be answered as it differs from one person to another and according to your general immunity and response. However, usually in such cases, you take 3 to 5 days in the hospital. And even before sending you home, we need to do some necessary arrangements. Ah, doctor, that's good because I'm worried about going back home. Why you are worried going back home? Because doctor, she lives alone. So here in this case, if someone is living alone actually, and she doesn't have anyone to look after her, okay, now we can reassure her. We'll arrange someone like a carer provided by social services to look after her for after discharge. So if someone is living alone, I told you before, if someone is living alone, you can arrange a carer which is provided by the local council to her to look after her after the surgery. Doctor, but how will I go around? How will I get around? Usually we assist our patient before going home. How? Physiotherapist. Now we can explain about physiotherapist and he will assist her walking ability and her mobility before sending her home. And we will provide you with the walking aid as well. So for the mobility, I always mention the physiotherapist and the walking aid for the first few weeks. When can I go back to my normal activities? This is major operation, guys. Again, the question how long will be answered, it differs according to your immunity and your body response. However, generally speaking, this is a big surgery. So into normal activities, it takes up to 8 weeks. 8 weeks here to go back to the normal activity. However, here, because this is hip replacement, the hip replacement sometimes can take up to 1 year to function properly. Okay, now she will ask you one more question. I live in a house, my bedroom and kitchen are on the same floor, but my bathroom is upstairs. You know what this means? She's speaking definitely about the occupational therapist. So when she mentions about the movement, you will mention the physiotherapist assessment. And about the home condition, you will mention about the occupational therapist assessment. He will definitely assess your home and see about your home conditions and to make necessary arrangements sometime. For example, for the stair, for climbing the stairs, you can set temporary escalator or even electric wheelchair so that you do not climb the stair. What about the shower? For the shower, actually, the chair can be fixed in her shower room. Why? Because she needs a chair in her shower room, chair in the shower room, because why? The shower room is a common place for fall. Okay, so here definitely this is the arrangement for the shower which can be done. When can I have food or drinks? Okay, definitely, we wait after the operation till the effect of the general anesthesia or the dizziness which is caused by the anesthesia wears off. And if she is able to tolerate food of fluids, we'll definitely give her sips of water. Usually this happens on the same day. So now you'll give her warning signs like if you develop any shortness of breath or any redness or swelling in your legs, please come back to the A&E immediately. So again, this station is about the blood clots, how to prevent them, number one. Number two, She's living alone. You need to arrange a carer to her. Number 3 as well, she asked about the hospital stay, usually 3 to 5 days. Number 4, very important, about the mobility, mention about the physiotherapist. Number 5, about her home condition, she lives alone. You will arrange a carer. Number 6, home condition are not suitable, like they are not on the same floor. Now you will ask for the occupational therapist. How can I have a shower? Chair in the shower room. Food or drinks usually after the effect of the anesthetic wears off, usually on the same day. This is a station so far, very easy station, apart only from 2 questions about the duration, which you can always answer. This differs from one person to another. Here, the data gathering here will be the data gathering for the pulmonary embolism. And sometimes for the risk of developing blood clot. And sometimes she is not answering you. She is nervous. I mean, she's anxious and she wants to know about the post-operative arrangements. If you have to, usually you will not have time. Maybe you can ask, for example, some questions about the hip pain itself. Like, man, how are you feeling right now? Do you have any pain, any swelling? Like this. Like 1 or 2 questions. But usually this lady will not let you take beyond the blood clot history, the assessment of the blood clot. Okay. One other station is the vascular surgery bypass. This vascular surgery bypass station, it is sort of complication after surgery. You know, she had aortobifemoral bypass, and she has bad bleeding afterwards. Definitely, this is one of the risk factors, or this is one of the complications after the surgery itself. Your FY2 working in vascular surgery department. The patient is 65 years old, female patient. She has undergone aortobifemoral bypass graft due to vascular insufficiency. Other information, she has shifted to the recovery room after the operation, but your nurse colleagues have noted that she has been bleeding heavily a few hours after the operation. She was given 6 units of blood. 6 units is very much. Your colleague all rushed to the theater. She was taken to the theater for re-exploration. Please talk to the husband, address his concern. Special note, no consent has been taken to talk to the husband. Sorry, special note, consent has been taken to talk to the husband. And there was no error in the surgery. So this special note is there is no error in the surgery. Again, there is no error in the surgery. Please mind this. Okay, now I prefer that if you consider it like sort of breaking bad news, but not detailed breaking bad news. You just have to elaborate it like this. So the husband will tell you, doctor, I came from work to see my wife. Where is she? What's happening? Now we assure him she's in good hands. Can you tell me what happened? So he will tell you, I took my wife to the hospital and she went back to, and I went back to work. I was at work and someone from the hospital called me and they told me that my wife's surgery was successful. After that, I received another phone call and they told me that my wife was taken to the theater. So here he knows that only his wife was taken back to the theater. Now you will tell him that your wife had a surgery because of problem and the operation went very well. However, after the operation, unfortunately, she developed one of the complications. Do you have any idea what happened? No, doctor, tell me please. Now tell him that she started bleeding a few hours after the operation. Bleeding, which she died? Now I understand where you are. Let me tell you what we have done. First of all, she's in good hands. Team of doctors are looking after her. Like Joshua exactly. Team of doctors are looking after her. She is in good hands. Let me tell you what we have done. We have given her 6 units of blood, and we took her back to the operation theater. Doctor, 6 units of blood? They are too much, yes? You will tell him that yes, it's a lot, but you know, we needed to compensate for the lost amount of the blood. Doctor, will she die? Again, she's in good hands. Team of experienced doctors are looking after her. Doctor, but will she die? Again. Now you can tell him that when he asks you first, will she die? Always say she's in good hands. Team of doctors are looking after her. Again, doctor, but will she die? Now you can say that I'm afraid she's in a critical condition, but we are doing our best for her. Oh my God, this means that you have done a mistake during surgery. Something has gone wrong. Now you'll ask him, may I know why you think so? Doctor, you just told me 6 years of blood. Why this should have happened? This is too much. Now explain to him that this is one of the commonest complications after surgery. And it has been explained to his wife. I mean, now when someone asks you about any complication, say it is one of the commonest complications after surgery, and it has been explained to your wife by my colleague. And I can reassure you that nothing went wrong. Now he will ask you, doctor, but nobody told me about this. How come this happens? Now you will tell him that usually before the operation we explain to the patient all the possible complications. So the core here is to tell him that we explain to the patient herself. So his wife was aware about all complications here. I have lost so much confidence in you. Are you sure it was not error? Now you can explain to him the difference between the error and the complication. You know, simply the difference between the error and the complication is that, number one, the error is caused by some faulty technique or some fault by the medical or the surgery team, like the surgeon or the anesthetist or the health carers or the medical team also only. But the complication itself is an adverse event which happens, which can be influenced by many factors. One of them is the patient health. So the complication can be affected by the patient health, but the error is actually, the complication is influenced by many factors, including the patient health and the operation itself, the nature of the operation. But the error is something which happened as a mistake by the medical or the surgery team. Now, he will ask you, doctor, how you convince me it was a complication and it was not error. Now you have to explain to him that this is the nature of the operation. Now explain the operation to him. Explain to him that this was a major operation. Why? It is an operation which we insert an artificial vessel between the big vessel or the big artery in the tummy and the two vessels in the leg, which are big vessels as well. Now you know that's why the chances of bleeding are high. Doctor, what is this? This is one awkward question as well. Success rate, I will ask you about success rate of the operation. It is 95%. However, his wife has developed one of the important complications. And the good thing is that we are always prepared for such complications. That's why we took her directly for the theater. Doctor, I didn't know why I don't know why it was risky. As it was risky, why did she go for it? Or why did you ask her to undergo this operation? It was risky for her life. Why did you do it to her? Okay, now you can tell him that here the benefits outweigh the disadvantages. She was having prolonged pain in the leg, especially during walking. And also she was at risk of developing ulcers. And ultimately she could have lost her leg. So here, the aim of the operation was to relieve the pain and improve her ability of walking and improve her legs as well. So the advantages outweigh the disadvantages. Okay, doctor, what shall I do now? Shall I go home or wait in the waiting area? Simply tell him that the operation may take few hours. It's up to you if you want to wait for her here. Doctor, shall I call my children to come and say goodbye to their mother? You can simply call them to inform them about her condition. I'm sure you need them by your side more than any time before. However, sometimes, you know, I told you that this operation can take few hours. So if they live far away, if they live far away, you can ask them to, it's not important. You can ask them to come later if they live very far away. Okay. He will ask you one more question, doctor. What will happen after she goes home? Or sorry, what will happen after surgery? You will tell him that we usually keep the patient again. Hospital stay here is 1 week up to 10 days as well. However, sometimes you can stay a bit longer. But the good thing is that we never let her go home until we are absolutely sure that she is fine and she's coping well. Are there any other complications? Like the usual complications, I told you this is a surgery in the leg. So pain, damage to surrounding structure, numbness, infection. These are the most important complications. But the most major complication is the developing of blood clots, because this is a major surgery. Those are general complications. But here there are also special complications. What is a special complication here? The special complication is simply that she may develop infection in the graft itself or block in the graft. Infection in the graft, we are going to give her antibiotics. And if it happens or if it's not relieved, we can remove the graft. What about blocking the graft? We are going to remove the graft as well by another operation. And since it is a major operation as well, there can be some chances of paralytic areas, like ball block or ball slowness. And if this happens, you know what will happen in the paralytic areas? We'll give her IV fluids. He may ask you, doctor, what about after that? After going home? After going home, she will need to have rest at least for a couple of weeks. And she can start to hear activities gradually, should abstain from any physical activity, and she should be taught how to dress the wound. So like any surgery, refrain from physical activity, have enough rest, and do exercise or do walk gradually. And warning signs would be wound infection, redness or swelling or discharge, number one. Number two, if you develop any like redness or swelling in your calf itself, the calf muscle, or any shortness of breath, come back to us, the A&E. So redness or swelling means wound infection. So here, she can seek advice. But the most serious things is the redness and swelling in the calf or shortness of breath. This means that probably this is blood clot and she needs to go to the A&E. Okay, we will take a few minutes break, guys, and we will be back. We are left with one station, which is the hernia for surgery. After which, we'll discuss the OBG. I will aim at least 7 stations from the OBG. I mean, even if we finish the session today a little bit later, like maybe 8:30, still I have to finish the OBG at least 7 of them today. So we'll be having a few minutes break right now and see you in 5 to 10 minutes. Hello, guys. Sorry for the delay. Okay, right now we need to move to one other station, which is first. I see that some people have left. Okay. Why do people leave without telling at least? And they come later asking, we didn't attend this and we didn't attend that. Why? Okay. So next station is hernia operation. Simply, the guy here is set for hernia operation, and it will be done open surgery. It will be done as an open surgery, which means that there will be a cut made. Why? Because simply the guy blood pressure was 140 over 110. His blood pressure was high. That's why you cannot perform the surgery for him. Simple. You're going to do it open surgery. You know, the laparoscope needs general anesthesia. Open surgery can be done under local or spinal anesthesia ultimately. And general anesthesia, one of the contraindications of general anesthesia is high blood pressure. So, in this station, simply, what you're going to do, you're going to talk to the patient and you're going to discuss the operation to the patient in details. So here, you're going to explain the operation even after the operation. Special note, the preoperative assessment has been done. Preoperative assessment has been done, and that's how we could figure that his blood pressure is high. Now, you're asking the patient, assess the reason for the visit number 1. He will tell you, I have been planned for surgery, and I was told that someone is going to talk to me. Which surgery? Inguinal hernia. Take some history from him. Like, which symptoms did you have? He will tell you that he has some redness or pain, he has some swelling in one side of the body, like this. So swelling in one side of the body, or bulge or mass in one side of the body, this is how we diagnose that inguinal hernia. One important thing here to add is it reducible or not? I mean, could you reduce it back in its place or not? So again, what was the presenting complaint? He had swelling. Since when it started? How did it start? Has it changed? Has it been reducible or not? I mean, could you press it back to the place or not? Past medical history. It's the hernia, right? Why don't we ask about cough and constipation? Ask about other medical conditions like maybe diabetes, high blood pressure. You will tell your doctor your nurse colleague has measured my blood pressure and it was a bit higher. You just have to reassure him that we're looking after that. Any other symptoms? Like what? Or any other thing? Like any medications, any allergy, any family history of similar disease? His father had hernia when he was 50 years old as well. So there is a family history of hernia here in this case. Lifestyle, very important. Smoking and alcohol and physical activity. And actually, his job as well is weightlifting. He is like a building in a construction company. Now move to the management. Tell him how, he will ask you, doctor, how the operation will be done. Now you will tell him that it's going to be an open surgery. Do you know why? He will tell you, doctor, why? Because my nurse colleague has checked your blood pressure and it seemed a bit high. However, this doesn't mean that you have a high blood pressure because he was concerned in the middle of the history about his blood pressure. This doesn't mean that you have high blood pressure because we need to check it again and again at different times. But I'm afraid this is, in this case, we cannot put you to sleep. For that, we're going to do it as an open surgery. So due to the high blood pressure, we're going to do it as open surgery, not a keyhole surgery. Keyhole is laparoscope, and keyhole usually is done under general anesthesia. Okay, he will tell you that now what's your concern? He is having some other concerns. Like what? Like, for example, what is hernia? Simply, hernia is the bulge of internal part of the body, especially the bowel or the intestine, through weakness in the muscle. Okay, and when this bulge happens, this explains the swelling that you had. Most of the times, it goes down the way to the groin. So again, bulge of the intestine or the bowel through weakness in your tummy or in other structures. And mostly it goes down the way to your groin. Now he will ask you, doctor, should I take specific diet before the operation? You will tell him again, before any operation, it's advisable to have plenty of water and laxatives. Plenty of water and laxatives. Okay, how will the operation be done? You told him that it's going to be open surgery under local anesthesia or regional anesthesia, which is a spinal anesthesia. Which means in both cases you will be awake during the procedure, but the area will be numbed. This is number one. So this is before the injection or the anesthesia. How will it be done? Single cut will be made over the operation site. Okay, what happens? After the cut, okay, let's assume there is a cut. What happens is that the surgeon simply, he will place, there's a bulge of the bowl of the loop of the bowl. So the surgeon will open the skin and he will place the bulging part of the bowl back again its place, okay, and he will place a mesh over it. So he will pull it back into its place and he will place a mesh which acts as a scaffold like something like which enforces or something which like blocks or pressure over the bowl so that it does not, so it prevents the bowl from bulging back again. So again, press the bowl loop back again in its place and place a mesh over it, which means that the bowl loop is unlikely to recur. Okay. After doing that, the skin will be closed with fine stitches. So after that, the skin will be closed with fine stitches. Like any operation. Will it be painful? You will tell him we'll give you numbing agent, and there can be some pain after surgery, for which we are going to give you simple painkiller. Why we are not going to give strong painkiller, Dr. Zaid? Can you tell me? Dr. Zaid?
Because probably he's a smoker?
No. You cannot give a strong painkiller simply because of two reasons. Number one, because simply you will be giving him enough painkillers, enough local anesthesia. Number two, very important to say, that the painkillers or the strong painkillers cause constipation, and the constipation can worsen the hernia, right? The codeine causes constipation.
Right.
That's why actually it's unlikely, or it's most likely, that he will receive only simple painkillers if it ever happens and he's having pain. How long is the procedure? 30 to 60 minutes. Most probably 45 minutes. How long should I stay in hospital? Simply, it is a daycare surgery, which means that if everything goes smooth, you'll be able to go home after the surgery if everything goes fine. Will I have any pain? I told you that there can be some pain. However, we'll give you adequate painkiller to relieve your pain. Simple over-the-counter medications, like maybe paracetamol, ibuprofen. Okay? But advisable not to prescribe. I told you, no strong painkillers because they will increase the chance of constipation. Any other complications? Again, like any complication, infection, bleeding, blood clot in the leg, And sometimes there can be hematoma, which is buildup of blood. So again, infection, bleeding, blood clot in the leg, and hematoma. Those are the most important things. Okay, he will ask you, doctor, will I be able to take a shower or bath? Actually, we advise shower. Why shower? Because actually the wound will be covered and dressed, and it will be covered by see-through plastic dressing. See-through plastic dressing, which means that no water, nothing will interfere, nothing will go deep to the wound. So you can take shower usually. So it will be covered with plastic dressing. Okay. And the dressing as well is waterproof. This is one other reason. Okay. How should I take care of my wound? Now, you will tell him that my nurse colleague will explain to you about how to take care of the wound. Usually, simply here, you will tell him that do not change the dressing until it has become blood stained. The wound dressing actually is very appropriate. Like it's simple wound dressing from time to time, but do not change the dressing unless there is blood in it. Why? Because if there is blood, this means that definitely there is bleeding. So we advise you always to look after the wound in a case that it becomes clean and dry. Simple. Advise him to keep the wound as clean and dry as possible. But just if you notice any blood, please come to the medical team. And warn him about two things. Number one, if there is any local rise in temperature or any redness or swelling or bruising, come back to us. So signs of wound infection, if any signs of wound infection, come back to us. How long it takes to make complete recovery? Here it takes 6 weeks. And please start it with it differs from someone to another in the immunity and state. When will I be able to drive after the operation? Okay, for driving after the operation, simply 1 or 2 weeks. But in his case, it can take longer because it's open surgery. So usually it's 2 weeks, but because of open surgery, it can take longer. And again, it differs from someone to another, and it's advisable not to drive until you are comfortable with it, to take the break. Sexual activity. You can find it uncomfortable at first, okay, but it's advisable to have sex whenever you feel it. So driving if you are comfortable, and sex whenever you are comfortable with it. Regarding the work, because of his condition, he may take to 6 weeks. So everything in this station is 6 weeks because of his condition and his work. Exercise 6 weeks. Simple walking can speed the healing, but strenuous exercise or lifting can take up to 6 weeks. Doctor, will I have this again? It can be recurrent. The chance of recurrence or recurrence is one of the complications that we expect as well, especially in smoking and in the old age patient. What if the mesh failed? We'll ask you what if the mesh that you're going to place over the hernia, what if it fails? You're going to place another mesh. Very simple. One important question is that, do I have to wear truss? You mean truss like this? Wait, I'm just typing it. Truss is an old procedure which is not used right now. Very simple. And now thanks to the open and the laparoscopic surgery, everything has become easier. Warning signs: if you develop any severe pain, any nausea, any vomiting, it's a sign of wound infection, number one. Number two, if there is any signs of blood clot in the leg, come back to us. Or if you experience sudden tummy pain and sudden nausea and vomiting. You know what this means? This means that there is a chance of bowel obstruction. The hernia has become obstructed. Please come back to us. So signs of wound infection, signs of pulmonary embolism or blood clot in the leg, and signs of intestinal obstruction due to hernia. So again, everything in this station is 6 weeks, apart from having sex and driving whenever he feels comfortable. surgery will be done as open surgery. Why? Because his blood pressure was a bit higher, so no chance of putting him under general anesthesia. What if the mesh is infected? We'll take it out and we'll place another mesh. Okay, shower, he can take shower, and it's advisable to take shower. For recovery, 6 weeks. Everything 6 weeks. Complications, infection, bleeding, damage to surrounding structure, blood clot, and hematoma, like any operation. The procedure takes 30 to 60 minutes. Will it be painful? We will numb the area, and we will give him painkiller after the operation, but simple painkiller. Okay, so those are the surgery stations so far. Now we'll start the gynae. We need to be a little bit fast for the gynae stations. I know they can be hard to some people, and some people do not like the gynae, but fortunately we're only having 1 or 2 hard sessions for the gynae. Other things are easy. So anyone has any questions so far? Anyone has any question? Okay, let's move to the OBG stations. Before moving to the OBG, guys, I just remember something before leaving right now. What do you think about Friday session? Because actually on Friday I have some appointment like in the afternoon. I have to leave early, and I may travel. So what do you think? I prefer that if you do it in the morning. But let me stop. Oh, appendicitis came recently.
Then there would be diverticulitis again. There would be ovarian cyst.
Okay, what else?
Again, renal stones.
Yeah, PID as well. Ectopic pregnancy as well.
Again, yes, ectopic pregnancy, exactly, right? Yeah. And again, PID.
Exactly. So simply, that's it.
Just the appendicitis just drop off the list. And
no, appendicitis, no. Yeah, drop the appendicitis
on the left. Yeah.
And
on
put
the left,
diverticulitis instead.
Yes, instead of.
What about the center of the tummy? Central tummy.
Then it would be PID. PID first. Exactly the same in ectopic. It can be all over.
Most probably it is something in the bowel. If it is in central tummy, or it could be urinary, like UTI, especially if suprapubic. Suprapubic is UTI, and if central tummy is most probably something in the bowel, because this is the place of the large intestine.
Yeah, you're right.
Yeah, and most probably intestinal obstruction. If in central tummy, and sometimes diverticulitis as well. Sometimes. Okay. What about the epigastric pain? This is sort of quick review for that. I know we can be wasting some time, but this is important. Why? Because this will point you toward many things, especially in the combined station.
It would be GERD. It would be
sometimes
MI can present. Sorry?
Peptic ulcer.
Exactly.
What else? One station which may come at any time.
Pancreatitis?
Yeah, it can come at any time. Pancreatitis. Expect it at any time. What else? Cholecystitis as well. Thank you, Dr. Mahdi. Sometimes, the only presentation of cholecystitis is epigastric pain.
Preeclampsia.
Good. But preeclampsia most probably right upper quadrant.
But she has to be pregnant for that, no?
Huh?
She has to be pregnant for that.
Yeah, sure.
The third trimester.
Yeah, sure. She has to be pregnant.
We are talking about that she came.
No, I mean generally.
Okay.
Generally. Yeah. Okay. Those are the abdominal complaints so far. We spoke
because
about
in
the
this
back
patient,
in
this patient, we are not sure yet. What does she have? Do we?
You are not sure. You will not be sure. I will only tell you one thing, which can point you towards the ugly truth. Okay, Dr. Elvira, and that's why I always
Yes.
stress on it, because some people overlook it and they end up not reaching diagnosis. And what they do, they come out of the cubicle and they say we had a new station today, though it was not new. Okay, so let's speak about this interesting station. Dr. Elvira, I just need to map your mind quickly. Elaborate with me and I'm going to help you with that. I'm sure it will be fun. She's a lady, no, she's a girl. She's having 2 days history of pain.
She's 28 years old, is she?
Yeah, exactly.
Well, I think we can safely call her lady.
Don't think like now. Don't think right now. Just wait and listen to the patient's words. 2 days history of pain. She is presenting or she pointing toward right iliac fossa, and it started suddenly, and continuous pain, and getting worse, and it's dull aching pain, and it does not go anywhere else. And by the way, very important question to ask when the patient is having right iliac fossa pain. I need you to tell me, if you are going to tell me, you are going to be a hero. Just tell me what is the most important question in the elaboration of the pain of the right iliac fossa pain. What is the most important question in the right iliac fossa pain, Dr. Elvira? Quickly.
I don't know, does it go anywhere?
One more important question. I mean the most important one.
Okay.
Come on. Exactly, Dr. Mahdi. Where the pain started? This is the most important question. Why this question is important to Rivera? Huh?
I didn't understand. She clearly is pointing that the pain started in the right iliac fossa. She's saying lower tummy in the right side.
He is having this pain on the right side, but I didn't know till
Yes.
now where did it start.
I think you told us at the beginning of the station that she came in saying that she's having a lower tummy ache from the right side.
Dr. Elvira, you're having now a headache on your front in your frontal part of the head. Am I sure that this headache was in the same place when it was first presented? I need to explore it further. Why? Because I know that one of the presentation of the right iliac fossa pain is that it can start in the umbilicus, around it.
Okay.
When it started around the umbilicus, it can travel to the right iliac fossa. This is characteristic for appendicitis. Appendicitis pain starts around the umbilicus and then travels to the right iliac fossa.
Okay.
So this question is very important in the right iliac fossa pain.
Okay.
Are we clear so far?
Yes, yeah.
Okay, perfect.
I forgot surgery.
No problem, no problem. You'll just read it, by the way, you read it today and tomorrow and you'll be perfect for it.
Okay.
And she has tried some paracetamol and it didn't help her. What will be your next question after elaborating the pain, Dr. Elvira?
Does she have any discharge? Does she have...
Dr. Elvira, I will kill you.
Ah, okay, one by one, yeah. Is she pregnant by any chance?
Dr. Elvira, I will kill you again.
Okay. Anything else?
Yes.
Yes. Yeah.
See, in the beginning of the station, I told you, if you do not ask this question, you will not reach a diagnosis. And this is what happens to the candidates. Most of them, they enter the station and they ask about blah, 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 anything else, and they find nothing else.
Okay.
So if you ask about anything else, she will tell you, yes, doctor, I have noticed some discharge from my front passage. When did it start? 2 days ago. The color is green. And it's full smelling. Bad smell. Okay, and just some like small amount of discharge. So small amount of green discharge with bad smell. So this means that there is an infection, right?
Yes.
So infection plus tummy pain. What is the most important cause of infection plus tummy pain?
PID, then she's
exactly.
PID.
Exactly. This means that this is the discharge coming from the genital tract or the hair genital system. which means that probably PID. Right or not? Now I knew the diagnosis, Dr.
Yes, that's
Elvira. What will be your next question after elaborating the discharge?
One second.
Okay. If you are busy, just tell me. No problem.
I will ask about the discharge. Yeah, she actually described in her discharge.
Yeah. What's next?
It's anything else?
Yes, doctor. I'm having some fever. Sometimes she can give you fever. She will tell you, doctor, I had some flu-like symptoms like 2 days ago, but it went away.
Okay.
Okay. So now I have three symptoms. Now ask about any nausea and vomiting. You know, like any abdominal pain, nausea and vomiting.
Okay.
What are the symptoms of the PID? I got tummy pain so far and discharge and fever, or low-grade fever. What are the other symptoms? The two other symptoms of the PID are postcoital pain and postcoital bleeding. I'm going to ask her, do you have any pain during or after sex? What about bleeding after sex? So I will ask about pain and the bleeding after sex. What are your differentials here, Dr. Elvira? You think what are your differentials? Now now from the Socrates I excluded appendicitis.
Yes.
What are your other DDs?
She still can be pregnant, is she?
Ask about the period.
Ectopic pregnancy. Together.
Okay, the last menstrual period was 3 weeks ago.
Okay. Well, then we are left with
UTI.
UTI, yeah. Okay.
I told you, do not ever forget to ask about UTIs. Also, your differentials here are ectopic and UTI. Ask about the period and UTI symptoms. Past medical history is very important to ask the patient, have you ever been diagnosed with any medical condition? Have you ever been diagnosed with any sexual transmitted infection? This is the most important thing in the past medical history. Besides the family history, here I ask about the partner. Has your partner experienced, I mean like the partner experienced similar symptoms or discharge from the front passage? No. So here in the family history, I have to ask about the partner if he experienced discharge from the front passage or not. I asked about the period, Dr. Elvira, right?
Yes.
But I did not ask about the other piece, which are
pregnancy.
Pregnancy. You can think you still ask about pregnancy?
Pills, or maybe she has
pills, very important. So I have to ask her about other forms of contraception. She will tell you, yes, doctor, I'm using coil.
Yeah.
What do you think? Using coil, IUCD, and it was inserted.
It can increase the chances.
And it was inserted 3 years ago. It was inserted 3 years ago. Okay?
Yeah.
Okay, so you think it could be because of the coil?
No, it can't be, but still it can increase the chances of.
Yeah, okay, but it's not the high possibility here. That's why we need to take good sexual history. Why good sexual history? Because definitely the other most important risk factor for PID is STI. So ask about sexual history. Are you sexually active? She will tell you, yes. Is it a stable relationship? Yes. We met 2 weeks ago. We met 2 weeks ago. So
unprotected sex.
Protected sex, yeah, not really, doctor. We don't use condoms. So unprotected sex and started 2 weeks ago. The last time they had unprotected sex was a few days back. Any other partner? Yes, doctor. I had many partners in the past. Were you practicing safe sex with them? No. And she has been sexually active since 15 years. So now you know that she is not practicing safe sex, and she had previous partners and she was not practicing safe sex with them. Right?
Yes.
What could be the most probable cause here? The coil has been there for 3 years. but the partner
Yeah,
has changed 2 weeks ago, and she has been having multiple relationships with unprotected sex. What do you think, Dr.
Yeah,
Rubia?
that is STI. Yeah.
Exactly. So now do the examinations. So now important thing, these are UTI and ectopic pregnancy, and do not forget to ask about sexual history here. Move to the examination part. Which examination to do? Abdominal examination number 1, Dr. Elvira. Number 2, 1 pound if you say the other examinations.
Per what?
Tell me.
Per vagina?
Mm, by manual.
By manual, yeah.
Why by manual? Because I need to check for the adnexal tenderness, which is the ovarian tenderness, and the tube as well, tubal tenderness, and the uterine tenderness, and cervical excitation. So, in any bimanual examination, you verbalize these 3 things. Bimanual examination to look for 1, adnexal tenderness, 2, uterine tenderness, 3, cervical excitation. All because the task was telling you till the findings that you are looking for. So this is what you are looking for. Okay. So the examiner here at this point, okay, what else? Which other examination? Speculum examination as well. You have to do speculum examination to check for cervicitis or vaginal discharge.
Yes.
The examiner will give you, doctor, there is right adnexal tenderness and cervical excitation. I would like to do some investigations. Which investigations? Number 1, high vaginal swab. Why? Vaginal swab is to detect any bacteria. Number 2, blood tests, routine blood and routine urine, and transvaginal ultrasound. I said speculum, Dr. Mani. Speculum for vaginal discharge and cervicitis and proctitis. So the most important investigations are high vaginal swab, routine bloods and routine urine, and transvaginal ultrasound. The examiner will give you on the transvaginal ultrasound that the uterus is enlarged and thickened, and the ovaries are enlarged and inflamed as well, and fallopian tubes are thickened and inflamed and dilated. So all these findings point toward PID. What's going on? From what you told me, it seems that you're having a condition we call acute pelvic inflammatory disease or PID. What is this? Inflammation or infection in the womb and with or without the ovaries and the tube connecting them. Why did it happen to me? Most probably because of the sexual transmitted infection, the STI. So here the most probable cause is the STI. Now we are going to tell you what are you going to do for me. We are going to do further investigations. This is number 1. Number 2, we're going to start the treatment. What is the treatment here? Number 1, we'll give her some painkillers for the pain, tummy pain. Number 2, antibiotics for 2 weeks. Oral antibiotics for 2 weeks, and do not mention the type. Antibiotics for 2 weeks with some few advices. What are the advices? Number 1, she has to take the antibiotics regularly, and she needs to refrain from sexual activity till complete drug course. So at least 2 weeks, no sex. Okay. Everyone is muted, by the way. Everyone is muted right now. Number 3, we will review her in 3 days. Why? Because we may need to change her antibiotic according to the swab. And we may need also to remove the coil if the treatment is not responding. And we may need to admit her if she has developed any complication. So to change to review the antibiotic and to remove the coil, and to admit her if possible. Why? Because usually the complications may arise at this time. Number 4, we need also to review the husband. Remember, this is infectious disease, so we need to review the husband and offer HIV screening to her and to the husband. Unprotected sex together, so chance of HIV are high. Number 5, we will review her again after 2 weeks. Why? To review her antibiotic course, which is supposed to be for 2 weeks, to review if she developed any of the complications or not. Okay, number 6, we review her again in 4 weeks. Why in 4 weeks? To assess the husband again. So we'll assess the husband after 2 weeks and after 4 weeks. And we will also advise her about having safe sex in the future, and at least she needs to have full rest till she recovers. Okay. She will ask you one question, why did I get it? You will tell her most common cause is sexually transmitted infection since you had unprotected sex. Is my partner cheating on me? You will tell her that this STI here doesn't mean that he's cheating to you because it can be found in our bodies for long and they do not cause infection. This means that he could have got it from his previous relationships and you could also have got it from your previous relationships because you told me that you have been practicing unsafe sex. What are the complications of the PID? Number 1, recurrent infection. If recurrent infection happens, it can cause to have miscarriage. You know, the ovaries will be, the tubes will be inflamed and they will not be able to carry the baby regularly or the fetus regularly. So miscarriage. Sometimes as well ectopic pregnancy. Why? Tubal pregnancy. Because the womb may be inflamed, so the fetus will find no place to be implanted in, so they will go to the tubes. Any prolonged infection can cause pus accumulation, biosalpinx, just say pus or fluid accumulation. All the things, I mean, those many things can lead to infertility ultimately. Can I become pregnant? Well, usually in the worst cases, you can become pregnant because you are having the infection on one side, which means that the other ovary is functioning. This is the whole station. By the way, this station can be presented with other presentation. She can be presented only with abdominal pain. And when you ask her about anything else, she will tell you like what? Or no, she will tell you no. So now you have to rule out the UTI symptoms. You have to rule out ectopic pregnancy. And when you ask about the discharge, she will tell you, yes, doctor, I'm having discharge. So here the only difference is that you need to ask about yourself. Any question? Anyone has got any question? The follow-up again. Okay, Dr. Mahdi again. The follow-up will be, we will review her after 3 days. We may need to change the antibiotic according to the swab results. We may need to remove the coil and we may need to admit her if she developed any complication. And after 2 weeks, we'll review her again. Sorry, before the 2 weeks, we'll advise her to bring her husband for testing and screening, and we can also offer her HIV test. And in 2 weeks, what we are going to do, we review her in 2 weeks to review the antibiotic course and to review her husband and offer the screening tests to him. We review her in 4 weeks as well. Why in 4 weeks? To see if she is absolutely fine right now and she has not developed any complication. Again, this is serious condition, serious infection. And I will advise her to practice safe sex in the future because she has been practicing unsafe sex all the time. And I will advise her to have full rest till she recovers. Any further question? Okay. Let's move to that next session. Ectopic pregnancy, Dr. Elvira. This station comes these days as a combined station because it's short anyway. Short station. But here, you know, she will give you the presenting complaint as left iliac fossa pain. And the pain started since one night and is getting worse. Okay? And she has tried some paracetamol for it, but it didn't help.
Okay.
And it doesn't go anywhere else. And the pain is increasing in severity. It was 6, and now it's 8.
Okay.
Do you have anything else? You know what she will tell you? She will tell you, yes, doctor, I've got some bleeding. Some other time she may not let you about this. So what you will do?
I'll ask her.
About?
Is there anything else with the pain? Yeah, I'll ask, are you pregnant by any chance? And about her periods?
Doctor, I don't know actually, doctor, but my last semester period were like around 4 weeks ago. Or 5 weeks ago, sorry.
Are your periods regular?
Yeah, they are regular.
Do you think you're pregnant by any chance?
Yes, doctor, it could be. Because I did the pregnancy test and it was positive. See? Now you'll ask her anything else. Anything else, she will tell you.
Yes.
Sometimes she can tell you there's bleeding. Some other times she will tell you, no, doctor. So after she tells you no, what is the most important red flag? I mean, the most worsening pain. Like, you know, if there's any pain which is increasing like this, you know, the renal colic starts similar. I mean, it's continuous and it's like, it's a stable pain. It doesn't increase in intensity. It's always stable. Like it starts as a colic and it's always a colic. But here, this pain started last night and it's increasing in intensity.
Something is going on there, growing.
Yeah,
like
exactly.
A bleeding, like a bleeding.
Something which is like pressing, something which is like, how can I say, annoying.
Yeah, getting big in the size.
Exactly. Which is the tubal pregnancy. So this is the ectopic pregnancy. She will tell you, doctor, sometimes she can tell you, yes, I'm having bleeding. Some other times she can tell you no. So here you have to ask, number one, the most important red flag is that bleeding. Bleeding from the front passage. She will tell you, yes, doctor, I've got some bleeding. Now you elaborate the bleeding and you'll find that the bleeding started maybe 1 day ago as well. It was spotting. This is a bleeding and it is like darker than the period. So definitely now you know abdominal pain with sudden bleeding is ectopic pregnancy, especially if the periods are 5 or 6 weeks back. Right?
Right.
What are the other associating symptoms of the ectopic pregnancy? Dr. Elvira.
Nausea,
exactly.
Nausea, vomiting.
Nausea, vomiting, the most important ones, because you know from the severe pain, she will tend to be nauseated. What else? Amenorrhea. You asked about the amenorrhea. The last semester period was a few weeks back. And you asked about the pregnancy test. What are the other important DDs? The other red flag here to ask is the hypovolemic shock. How you rule out the hypovolemic shock? Simply ask her, do you have any dizziness? Very important to ask about this. Any dizziness or any fainting? Because this is one of the complications of rupture ectopic pregnancy. So the first DD is the rupture ectopic pregnancy, right? Number two, other DDs are like what? UTI. Don't forget about that. Or GIT symptom. I told you this is the left iliac fossa. Number one, ectopic pregnancy with its rupture. Number two, UTI. Number three, GIT problem. Past medical history, inconclusive. But there is a problem. She has been pregnant before. In any OBG station, we ask, like, instead of asking, did you have any similar episodes in the past, ask her, have you ever been pregnant before? This is in any OBG station. Have you ever been pregnant before? She will tell you, yes, doctor, last year, and it was miscarriage. At what age of pregnancy? She will tell you, doctor, 8 weeks of pregnancy. How was it managed? She went to the hospital and they did some tests. I just had to wait. So it was expectant management. So she had miscarriage before. You know, people with miscarriage are always at the chance of having ectopic pregnancy. How was your health recently? Okay, I ruled out the UTI and the GIT problems, right? I can also add the PID by simple question. Have you noticed any heavy or painful period? No, thank you. So there are 3 DDs. If you want to rule out 2 only, that's fine. UTI and GIT or UTI and PID. In the medical condition, she will give you that she had, okay, you have to ask her close the question here. Have you had any previous medical condition? She will tell you no. By any chance, any sexual transmitted infection? Yes, doctor. I was diagnosed with it. So now you have to ask about STI as well. Why? STI is one of the risk factors for having ectopic pregnancy in the future. The STI was when she was 15 years old. And it was managed by some antibiotics. Okay, family history, inconclusive. 4 P's, very important here. You can ask about the lifestyle as well, but do not spend too much time on lifestyle. Just smoking is very important. Now ask about the 4 P's. 4 P's, you asked about the last menstrual period, she gave you amenorrhea, and you asked about any heavy or painful period, she told you no. Ask about other pills. Why? Because the IUCD increases the chance of ectopic. She doesn't take any pills or oil. Okay, so now personal history, I asked about lifestyle, I asked about the 4 P's. Now what else, Dr. Elvira? The important set of questions for the OBG. Sexual history.
We ask sexual history.
We did not. We asked in the previous.
Okay, we have to elaborate sexual history. Are you sexually active? Do you have a stable partner? Do you practice safe sex? Any other partner by any chance? Yes, if she says that she had partners, then did you practice with them safe sex? If she didn't,
she had multiple partners and she was sexually active since long.
Well, that puts her at a high risk of ectopic pregnancy.
Exactly.
Doesn't it?
Exactly. So which examination to do here?
Exactly the same as before.
But there's something very important. Here you need to do,
pregnancy. We start from the pregnancy test. No, that is investigation. I'm sorry. We examine her tummy.
Okay.
And we will try to examine her bimanually. That probably will be very painful.
What else?
We will do ultrasound per vagina.
You can do the bimanual examination.
Yes, bimanual examination, yeah.
The examiner will give you tenderness only in the left iliac fossa on abdominal examination. But there is something you have to say here. You have also to, I told you that one of the red flags is rupture ectopic pregnancy. So you need to look for signs of rupture, which can be demonstrated by the vitals and the general physical examination.
Yes, yeah, that's correct, yeah.
Do not forget about that.
Vitals, yeah.
Okay. Management, what is the management? You're having condition. By the way, I told you that it can be combined. So you're going to do abdominal examination and you will find tenderness on the left iliac fossa on superficial palpation. You're having condition we call ectopic pregnancy.
But we don't know yet. We have to confirm that she's pregnant, first of all, and we have to do ultrasound and see that there is a pregnancy there.
Okay. Okay, this is a good point. But actually the examiner is not interested in listening to any investigations. Dr. Elvira, She is having amenorrhea for 6 months, and she is having bleeding, and she is having tummy pain. What is the
6
most?
months.
Yeah,
6 months.
6 weeks. Sorry,
Amenorrhea.
6 weeks. 6 weeks. Sorry.
Okay. So it seems that it should be a ectopic pregnancy.
Definitely.
With her history, yeah.
Yeah, but still, okay. I will tell you the further management. So you're having a condition we call ectopic pregnancy or tubal pregnancy. What is it? Pregnancy outside the womb, usually in the tube connecting the ovary to your womb. What are you going to do for me, doctor? Here, this is an emergency, right? So what's your step, Dr. Elvira? Number 1, keep in the hospital. Number 2, inform senior. Okay?
Okay.
Okay, we need to give her some painkillers and anti-sickness medication because she told me that she's feeling sick and she's having pain. This is the initial thing, otherwise she will die of pain. So, doctor, I don't want to stay in hospital. Why?
May I ask why?
Yes, exactly, because I don't want my parents to know. So you will tell her that I can imagine it can be frustrating, but it's very important for you to stay in hospital because we need to do some further tests. Which test you can expect, Dr. Elvira?
So there I come with my pregnancy test and with my ultrasound.
Exactly. You are going to do the transvaginal ultrasound, which is ultrasound on the front passage. This is the most important thing because it can identify the location and the site of the ectopic pregnancy. So number 1, transvaginal ultrasound. Number 2, special test to detect the level of pregnancy hormone, the beta HCG.
Yes. Yeah.
So again, for the ectopic pregnancy, I'm going to write it to you: transvaginal ultrasound and beta HCG. Do not ever forget about them. These are the diagnostic and confirmatory things. Can I come back up for the test tomorrow? What do you think, Dr. Elvira? Can she go and come back?
No, we can't let her go.
Why?
Because she might bleed. The bleeding will be continuing.
Exactly. So if it ruptures at any point, it is an emergency. If it ruptures, it's an emergency. So you need to tell her about this. But doctor, I can come to the hospital if anything happens. You told her about the pregnancy which can rupture, okay?
Yeah, unfortunately, it may be life-threatening. We don't want it to happen.
Doctor, but I don't want my parents to know. So she is awkward. She's stubborn. What are you going to tell her right now?
I do understand your concerns, but we don't want anything serious to happen to you, and certainly your parents don't want it either. So we will keep you in for a while, and we'll probably inform your parents. You need support at this time.
Yeah, okay.
No?
Actually, at this point, she's not interested. This is an emergency. You can tell her what you told. Exactly. You need their support.
Yeah, how old was she? We have to see her competence.
I think 18 years old.
No, she's competent enough, but
yeah, exactly.
Anyway, we have to explain her that it's life-threatening condition.
Exactly. So you will tell her that if it ruptures, you may need the treatment immediately. We need to give you fluids, and in alternate case, I'm afraid we may need to send the patient to the theater. So what are you going to do for me, doctor? According to the ultrasound result, we're going to decide on the management. What will be the management? Number 1, expectant management. Just wait and see for 1 week. This is expectant management. Follow up by ultrasound, wait and see. Next option is medical treatment, methotrexate, which shrink the pregnancy or stop the pregnancy from growing. So number 1, expectant, wait and see. Number 2, medical. Number 3, surgical management, surgery in which we do operation to remove the pregnancy. What can be suitable for me? This will be decided after the result of your test. And we will consider your personal preferences as well. Anyone has got any question here?
Just before the management, for disclosure, the diagnosis, you said that can we do the pregnancy test, urine pregnancy test, for more confirmation?
You can, but the examiner is not interested. I
Exactly.
mean, the examiner,
So
he will not reply to you.
Yeah, but
you can do it. You can do it.
We can.
No problem. But she told you as well that she did the pregnancy test. If you want to confirm it back, I mean, just to confirm, you can verbalize it. It's not a big deal. But the important thing is still, I mean, even if the examiner did not answer you, now you know how to, you know that you should say ectopic pregnancy.
Right.
Okay.
I should say, or I should say, we expect you have a condition called ectopic pregnancy.
Excuse me?
Should I say you have a condition called ectopic pregnancy, or should I say we expect that you have condition called ectopic pregnancy?
I suspect that you're having condition called ectopic pregnancy. This is a better way to say it all the time.
Okay, fine. Okay.
Okay.
Mm-hmm.
Okay. So, next station is the ovarian cyst, the dermoid cystectomy. Dermoid cystectomy simply it is an operation. So for any surgery operation, we are supposed to, this is considered as a counseling station as well. Okay, here she is planned to have ovarian cystectomy. By the way, this will be our last one. We'll be left with preeclampsia, miscarriage, and contraception. Preeclampsia, miscarriage, and contraception. And the PCO, I will send you the recording to it this night. I will send you to its recording this night. This is a new one, and only one concern has been asked so far. Can I be pregnant or not? Dr. Mahdi, I just noticed. Okay, no problem, Dr. Safa. This is our last station anyway. Dr. Mahdi, if you have bad pain on the superficial palpation, always ask the patient, shall I proceed or would you mind if I proceed? She will tell you no, don't proceed. And if she tells you, she will try to show you that she's in pain, but okay, you can go. But okay, just try to do it and just place your hands again and she will give you more pain. So please, okay, I'm sorry, excuse me, I will not go further. So just exclude the patient first, and if the patient is comfortable, go for it. But if she is not, please do not risk that. Actually, still miscarriage, contraception, and preeclampsia. No, we are left with 4 stations actually. We will do them tomorrow, inshallah, together with the pediatric station. But we need to start a bit earlier tomorrow. Can we start a bit earlier tomorrow, like maybe 15 or half an hour earlier? Okay, I will consider that. No problem. So now let's move to the ovarian cystectomy. The lady is set to have the ovarian cystectomy operation. Her cyst was 8.5 centimeter, okay, and she is set for the operation. She is having some questions. What are the questions usually? She will ask you, doctor, first of all, I'm set for an operation. Ask her for the reason of the visit, what symptoms. She will tell you pain during sex and very bad tummy pain. Now, she will ask you about the operation. Doctor, what is ovarian cyst? What do you mean by finished letter, Dr. Elvira? Tell me.
I meant rather than starting early, maybe we'll finish later. I mean...
this may be applicable to you and me, but not to the others.
Sorry.
Yeah, I know it's fine, it's fine. Okay, so here we're going to explain to her what is the ovarian cyst. Ovarian cyst, simply cyst is a fluid-filled sac. It is fluid-filled sac which develops from the eggs-producing cell in the ovary. Happens for no reason usually. Okay, doctor. So what about this operation? Tell me about the operation. There are a few points to tell her. Number one, I told you before the operation and during and after. Before the operation, usually what we do, she will visit us, like she will visit the nurse and the colleague, the anesthetist, to do the pre-operative assessment to her. And she will be advised to empty her bowel or take laxatives, like before surgery, to empty her bowel. This is number one. Number two, during surgery itself, you know, it will be made as a bikini line incision. You know what is a bikini line? Bikini line is just like the bikini line incision just below the umbilicus. And just sometimes the examiner will give you a diagram, not a diagram, they will give you like a paper, and you should only write the type of the incision. I mean, how the incision looks like. Simply bikini line. Yeah?
Dr. Ahmed, it's not below the umbilicus, it's further down.
Yeah,
it's
way below, way below, yes, way below.
It's right on the top of the pubic, and
yeah,
it's
very known. I mean, for the people who do not know it, it just, you know, how can I say? Okay, let me send you the photo. Let me send you the photo. Or even you can check it. If you check it on Google, just write bikini line incision. You guys, you will find it very clear how it's done. Like the cesarean section operation. It's almost the same. So it will be done as a bikini line incision, which means that there will be a cut. Actually, it will, yes, it's finished steel or finished tile. They said finished tile. It will be like a wide incision. Why wide incision and why big incision here? We need to make this big incision because actually the size of the cyst was 8.5. You know what does this mean, Dr. Elvira, to be 8.5? It's big.
Yeah, it is big, and you need a wider access to it.
Exactly. So we need to open wider to explore surrounding structures, like maybe the nearby ovaries. So we need to do wide incision to explore the other the nearby or the attached ovaries because the cyst is big in size. Doctor, and actually, unfortunately, and not unfortunately, actually, in some times we may need to remove the ovary as well. Doctor, will my ovary be removed? Well, we may consider that, but as you know, that the size of the cyst is long or is big, sorry. So we may need to consider removing the ovary here. But why, doctor? You know why we may need to consider removing the ovary, Dr. Elvira? Usually in big cysts, they are very close to the ovary.
It sort of engulfs the ovary altogether.
Exactly. And what else? The chance of rupture, the chance of torsion of the ovary are high. You know when something big pushes the ovary? I mean, for example, if you are hanging something on the wall and there's something heavy attached to it, definitely the heavy thing will fall down or the heavy thing will rotate from its place. It will push on the ovary. So the chance of ovarian torsion here are high, right? And the ovarian torsion or rupture are emergency. So better to remove the ovary. Number two, she will ask you, doctor, could it be cancer? Yeah, I know why you think so. I'm just worried about cancer, doctor. Okay, now at this place, you simply tell her that usually in your case, or 95%, it's not cancerous. However, the chance of having cancer or to be cancerous are higher in the menopause people or the menopause lady, and this is not the case for you. So only in the case of menopause, I'm worried about cancer, but she is not menopause yet. She is just 30-something years old. However, to make sure, we are going also after removal, we're going to send it to the lab. Anything or anyone who asks you about cancer, we are going to send a sample to the lab. always answer this question. In any 1% chance of cancer, you will always send the biopsy to the lab. Okay? What's next? 2 more questions to ask. No, not 2. Actually, there are more questions. What are the complications of the cyst? You told her number 1, rupture. This is an emergency. Number 2, torsion, another emergency. Number 3, in some rare cases, it can turn cancerous. And that's why we need to remove her by every chance. In case she tells you, doctor, is it essential that we remove it? Now you have to tell her about the 3 complications, and that's why we need to remove it. And one more thing, it has caused her bad pain. So in the case of the bad pain, definitely we need to remove it because it's symptomatic. It may compromise her life. Doctor, one more question. What will happen after the surgery? After any surgery, we remove to the ward, and if we remove to the recovery room, and if everything goes smoothly, we send to the ward. Will I be able to drink and eat? Again, when the effect of the anesthesia wears off, you can be able to eat and drink. We start by sips of water, like any surgery. Doctor, will it leave a scar? Actually, in this case, it has been written that you will use a special type of suturing, subcutaneous suturing, dissolvable stitches. So you will tell her that it may leave a scar, however, we will need to make sure that this doesn't happen, or we will minimize this by using special type of suture we call subcutaneous suturing, binding the edges of the skin in a very minute or very careful way. What else? What could be the other complications of the surgery itself? Complications of surgery are like any surgery. Infection, could be a chance of bleeding, could be a chance of, maybe in the worst cases, chance of formation of blood clot. And we are going to deal with that in the same way in the previous station. Usually she has some more concerns, like, when can I go back to work? Doctor, I do office job. You know, in this case, still, I have to tell her that you still better not to go work except after at least 6 weeks from now. Why? Because the incision is big. If the incision is big, it's advisable always to have full rest. Like, don't go to work, don't perform like these activities or these tiring activities regularly. What about having sex? 6 years after 2 weeks, whenever she feels comfortable. Doctor, will it affect my sexual performance? Actually, here it will improve your performance. Why? Because one of the complications of the ovarian cyst is that it can cause some pain during sex. Okay. She can also ask you about driving as well. Again, it differs from one person to another, but you will do it usually as you are comfortable to take the break. Other physical activity is better to abstain from them at least for 6 weeks as well, like the work. Is there any other question? No, doctor. Thank you. This is the whole station. And very simple station, very nice girl. And usually she does not ask all these questions. She will ask you maybe 4 or 5 questions only. Is there anything else you want to add? Anyone wants to ask about anything? Okay, so for tomorrow we're going to start a few minutes earlier. I need to finish 2 stations in 15 minutes, which are the contraception, the pre-eclampsia and the miscarriage. The pre-eclampsia and the miscarriage, I'm going to do them quickly. And after that, we're going to do the contraception and the gonorrhea. We're going to spend the first 1 hour for the OBG, and the remaining 3 hours are for the pediatrics. We need to be fast in the pediatrics, so please tomorrow, please, I advise all of you to go through the pediatrics station. I will post the list today. I will post it earlier so that all of you will go through the pediatric station before starting. I don't need anyone to be lost tomorrow, because tomorrow we are supposed to finish many things as well, pediatrics and OBG. Okay, so please read tomorrow so that we will save more time. Just read and follow me. Read and follow me. Thank you all, guys, and see you tomorrow, inshallah. And have a good night. By the way, we'll be having a mini session on Zoom after half an hour for anyone who's interested to practice or anyone who's interested to join. We'll be practicing the warfarin guy with learning disability who wants to join and who wants to practice. If anyone wants to practice, tell me in WhatsApp right now. So thank you guys and have a good night.